Hel, hel, hel. Hello, 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 mic testing, hello, hello.
A very good morning to one and all present. And I warmly welcome all of you to the second day of this conference. I take this opportunity to thank all the officers, speakers, delegates, and participants for making yesterday's event a great success. And we begin today from where we left yesterday. We will start with the oration of Dr. B.N. Ghosh sir. But firstly, I would like to call upon stage Dr. M.C. Pawar sir to chair the oration of Dr. B.N. Ghosh sir. And I request Dr. Ravi sir to please accompany Dr. MC Pawar sir to the stage. Sir is among the founder members and advisors of RISA. He has traveled all over our country for spreading awareness about the field of anesthesiology and integrating the railway anesthesiologist. Sir has become an institution in himself in the field of railway anesthesiology. He started his career in anesthesiology more than 50 years ago. His every step is dedicated to the foundation and sustained progress of RISA with the aim of selfless service to the welfare of our society to promote health, universal brotherhood, love, and peace for all. Now we begin with the oration of Dr. B.N. Ghosh sir. Dr. B.N. Ghosh sir was the first qualified anesthesiologist of Indian Railway Medical Service. He worked in B.R. Singh Hospital and Howrah Orthopedic Hospital of Eastern Railway. Late Dr. A.R. Das, anesthesiologist of Eastern Railway, donated the money in memory of his friend Dr. B.N. Ghosh sir in order to institute this oration. And I would like to call upon stage our respect controller. I would like to call upon stage Dr. Maheshwari sir, Chief Consultant and Senior Consultant NBE of NF Railway Central Hospital, Maligaon. Sir is a stalwart of the Indian Railway Health Service and a visionary in the field of anesthesiology. Sir represents the pinnacle of clinical excellence and administrative brilliance. Sir's academic and early foundation Sir began his journey at Guwahati Medical College, where he completed his MBBS in 1986. Dr. Maheshwari joined the IRHS that same year. His early career took him across the Jabalpur and Solapur divisions of Central Railway and the Lamding division of NFR before he returned to his roots at Guwahati Medical College to complete his MD degree in anesthesiology in 1996. Sir as an architect of modern healthcare, Dr. Maheshwari's legacy is etched into the very walls of the Central Hospital, Maligaon. He was the driving force behind the complete modernization of the Department of Anesthesiology, commissioning the seamless major operation theatre and installing critical life support infrastructure, including the medical gas pipeline system, the cryogenic liquid oxygen storage, and PSA oxygen generation plants. Sir as a visionary leader. As the first DNB coordinator in 1998 and later during his tenure as medical director from 2016 to 2022, he transformed the Central Hospital into a center for academic and clinical excellence. His leadership during the COVID-19 pandemic earned high accolades from the government of Assam, standing as a testament to his resilience and crisis management skills. Dr. Maheshwari sir as a policy reformer. As Chief Health Director and Principal Chief Medical Director from 2022 to 2024, Sir redefined the NFR medical landscape from introducing 40 HVS posts to streamlining the procurement of emergency medical boxes, a model later adopted by all the zonal railways. His administrative foresight has ensured that patient care and customer amenities go hand in hand. Sir has a legacy of mentorship. Beyond the machines and the medicine, Dr. Maheshwari has been a dedicated mentor. By introducing the paramedical training and revitalizing the DNB programs, he has ensured that the next generation of healthcare professionals is grounded in the same evidence-based practice he champions today. Sir as an orator. For his 4 decades of unwavering service, his transformative impact on railway healthcare infrastructure, and his standing as a doyen of anesthesia, the organizing committee of 31st RAISACON is honored to invite Dr. Parmanand Maheshwari sir to deliver the prestigious Dr. B.N. Ghosh Memorial Oration. A big round of applause for Dr. Maheshwari sir. First, we will like to felicitate our respected Dr. Parmanand Maheshwari sir. And I would request Dr. M.C. Pawar sir to please felicitate our Parmanand Maheshwari sir. I request you all to please give a big round of applause. Thank you, Dr. Pawar sir.
Good morning, everyone. I will be repeating because I think mic was not on. Uh, Respected Chairperson, sir, and ladies and gentlemen, first of all, I thank the RAISA for bestowing upon me this honor of oration. I will completing 40 years of service. I joined in 1986 in Central Railway in Solapur Division, and now I am here. You have already seen. During these years, whatever I could do, I have done best of my possibilities. And now let's talk about the topic. In health services, there are 3 drivers in these years. Number 1 is, of course, evidence-based medicine. Number 2 is telemedicine, which includes, robotics and telesurgery. And the engine of these 2 is the AI, which is coming next now. So with these 3, we will be taking revolutionary steps in improvement of service, the access to universal access rather, with these 3. Now, we decided that this time the topic should be evidence-based medicine. So what is evidence-based medicine? Evidence-based medicine is based on the integration of best research that we have with clinical expertise and the patient values. This was said by David Lawrence Sackett. He is considered the father of evidence-based medicine. He is a Canadian physician. This is a systemic approach where we analyze the availability of research that we have today, and based on that we decide certain guidelines which are normally issued by the professional organizations, our professional associations. What are the drivers of EVM adoption? Converging factors that drive the increased adoption of evidence-based medicine is experience without update. The leading cause why we want evidence-based medicine is experience without updates leads to performance decline. If we continue talking about only our experience without dealing with the whatever evidence we have, we will be deteriorating in our practice. That is what is happening. We'll be coming to next. There is rapid literature expansion. Every year there are a lot of research going on, and that research, we must take benefit of that research. The next issue is that there is increased access to this research to patients. Patients are also aware of what is going on. If we continue the same practice, the typical practice, a patient may question you that this is the research, this is Cochrane library, this is written, what you are doing. These kind of things we need to avoid, because we will have to take benefit and accordingly we will have to upgrade. Time constraints on learning, because for an individual physician it is not possible to know what is the research how he will analyze and how he will put it into practice. So on behalf of individual physicians, there are certain organizations, the professional organization, who makes guidelines, and that what we are supposed to use. There is increased demand in accountability. Accountability means, again, same, the patients are also demanding that we need to be accountable, because whatever research is going on, the benefit must go to patients. There is evidence-based, there is need for structured evidence, because the analyzing the evidence, for example, even if it is an RCT, which is supposed to be a very good evidence, but still the quality of the design of the RCT, for example, the available bias in the RCT, that need to be decided by eminent persons who are expert in research. Now another comparison is that textbook based practice versus evidence based medicine practice. For example, when we started, it was all textbooks only. So why we should shift over to evidence based medicine? Why we should focus on evidence based medicine? This is what comparison we are trying to make. The standard textbooks and expert opinion is there, but based on that, the publication cycle is very slow in case of textbooks, because textbooks has certain doctrines, they are very rigid, so they do not change. Textbooks are not changing that fast, the way the evidence is changing. So modern practice is that we cannot leave behind textbooks also. The textbooks are designed to have a foundation and give a concept on the basis of which we will work on the evidence, and our practice will have evidence-based medicine. Now we'll be talking about some pioneers. One of the pioneer I already referred to, David Sackett. We'll be discussing about three pioneers. The first one is Archibald Lyman Cochrane. As you have heard of him, he is a British epidemiologist who criticized that there is lack of evidence. The story is quite interesting. Lyman Cochrane, he was suffering from porphyria. So he was under treatment in England, and he found he was quite dissatisfied with the kind of treatment he was receiving. Then he was referred to Germany for psychoanalysis. As you know, in porphyria there are psychiatric symptoms as well. There he went for psychoanalysis, and there also he was very dissatisfied that the kind of physicians, the way physicians are practicing based on their own expertise and things like that, that was not sufficient, and he was totally dissatisfied with the kind of practice the physicians are forwarding with. With this, he published a book which was called Reflections on the Healthcare. So that book was the driver for RCTs. That book incited everyone to think about RCTs in research. Next one was Gordon Guyot. He was a Canadian physician. He was in McMaster University where he worked, and he was the first person who termed the practice as scientific medicine. But with this practice also, when he termed it as scientific medicine, his colleagues started saying that if you want to say that this is your scientific medicine, that implied that the current practice we are doing is unscientific. So he had to rebrand it as evidence-based medicine in 1991. We'll be talking about David Lawrence Sackett. He is an American Canadian physician. He is considered the father of evidence-based medicine, and he famously said that half of what we learn in medical school is dead wrong. These are the three pillars of evidence-based medicine. We need to consider the clinical expertise and the whatever infrastructure we have. For example, supposing in our hospital there is no PCI facility available, so what we are supposed to do, and if in case the PCI, where the PCI facility is available, in this case at what time we should forward, that is about the infrastructure. Best research evidence, we'll be talking about best research, what is called best research evidence, and patient values and preferences. There are certain recommendations which are, trade-off, borderline. There may be little bit of benefit, there may be risk also. Risk or benefit may be almost equal. In that case, we can always consult the patient regarding what is his preferences, his ability to pay. An optimum decision is taken through this Venn diagram. You can see the center is optimal clinical decision. These are the objective of evidence-based medicine. We will be coming to these objectives one after another. This is what I am talking about, hierarchy of evidence. As all of we have done little bit of research. So if you see here, the expert opinion and based on clinical experience is the lowest level of evidence. And if you see the x-axis, the highest level is meta-analysis of systemic reviews. And the y-axis is the quantity of research, or quantity of the expertise, or whatever you say, that research element is being shown in the y-axis. So still the medical practice, the chunk of the medical practice is based on expert opinion. As you can see, the observational studies are at lower level, and the RCTs, and based on that systemic reviews, and then finally at the top is meta-analysis of systemic reviews. Now going ahead, how to analyze the evidence, we have a five-step approach to finding the evidence. First thing, it's like what we do in thesis. First thing is we need to ask a question. We should have a question that we need to frame a question that what is our gap, and that we will have to decide. Second is we will have to find research, and this search has become very easy after introduction of AI. Then we will have to appraise that evidence. We will have to find out the evidence. For example, we have an RCT. That RCT may be downgraded to a lower evidence in case the design is not good, in case there is a bias element, in case the sample is low, in lower side. That way we can downgrade also. Then we will apply it to the patients in the form of guidelines, and after that we need to assess it, that what is the benefit of that implementing that guideline. In case we find something, then again the cycle will start. Now this is the PICO format. This is quite known to all of the students, or all of we who have done thesis. This is PICO format. We do what is the problem. First the question is what is the problem. Then what intervention we want to do, diagnosis, treatment, prognosis. Then we need to compare. Compare means whatever we are doing and what we want to do. Then outcome, what will be the outcome, what outcome we have accomplished, what we want to accomplish, whether we want a better treatment, whether we want a better prognosis, what we want to do. First, this is the second step, where the research question we need to start with 2-3 search terms, then we refine whatever is needed, then we use reliable database, for example Cochrane, and then we'll focus on what is the quality of that research based on whatever is based on the design of the study, based on the sample size, based on what is the bias that has entered into the service on the study. After that, we need to appraise the step 3. We need to appraise it. Then next step is apply that evidence. We will combine the evidence with expertise. We consider resources. We include patient reference. We discuss patient preferences. We need to discuss the findings, and we make shared decisions. That is what we do. This is the whole cycle. We'll assess, then we'll identify the improvement, we'll refine the process, we'll document whatever we are doing, we'll share the knowledge, and then we'll review the outcome, and again we'll find the gap, and again we'll ask the question. It's a cycle. Now coming to the final thing is that how do you grade the evidence? There are certain organizations who have made detailed protocols how to analyze evidence and how to convert it into guideline. There are very popular grading systems. First, the most popular is called grade. A grade basically refers to grading of recommendation, assessment, development and evaluation. More than 100 organizations are using this system, and the primary users are WHO, Cochrane and NICE. The evidence level here are divided as high, moderate, low and very low. The recommendations are said to be as strong and weak. Next level, which is very popular, the system is OCBM. OCBM means Oxford Center for EBM, Evidence-Based Medicine. This is in Oxford University, and they have divided the evidence as level 1, level 2, 3, 4 and 5. And accordingly, they have also graded the recommendations as A, B, C, D. Similarly, now these are the two organizations whose system is adopted by all the professionals organizations all over the world. And the major professional, I am just giving a reference to a very common what we are facing as anesthetists. As you know, we talk about perioperative cardiovascular management of non-cardiac surgeries, where we think about American Heart Association and American Cardiology College of Cardiology, where they have also have their own style of dividing the evidence, and accordingly they classify recommendations also. But although these professionals organizations, they have their own customization, but it is basically based on grade and OCBM. This is what we do. Yesterday, Dr. Kangan Sharma was discussing on this. He has detailed, he presented one this thing, and he had one presentation here in 20 minutes in last part. Probably all of you have heard. Where the class of recommendation is class 1, class 1, class 2B, class 2A and class 3. All of you know, I hope, that the class 1 is strong recommendation and class 2A is reasonable to perform, moderate recommendation, and class 2B is may be considered, and class 2B where the question of talking to patient comes. Patient preferences are considered where the evidence is not very strong, benefits are almost equal or little bit of benefit but risks are there. There where we consult the patient's preferences. And that is why in evidence medicine the three pillars, the one pillar is patient preference. Certain recommendations we would like to adopt in a patient who is agreeing to that. There is question of cost also. And class 3 recommendation should not be done. So this is how AHA classifies, but every organization have their own classification. Here one thing has been said, that level A is RCT meta-analysis, level B is randomized or non-randomized clinical trials, and level C is limited evidence or expert opinion. This is something which we need to consider, is that level A evidence doesn't mean that strong recommendation, and level 5 evidence doesn't mean weak recommendation. They are not linear, there is no linear relationship. For example, a strong recommendation may be that even a clinical expertise may be a strong recommendation, because beyond that there is no recommendation available. Beyond that, there is, beyond expert opinion, there is no other level of evidence available, and there is no need. For example, there are certain processes which are confirmed and they are absolutely beneficial. For example, the recommendations are based on what is the benefit and what is the risk. If benefit far exceeds the risk, that is a strong recommendation, irrespective of what the research level is. For example, in some research, there may be that expert opinion is available, but it is confirmed, and there is no need for further research. In that case, expert opinion, which is considered lowest level of evidence, that will be a foundation for the strongest recommendation. Again, for example, there is a strong evidence. There may be a meta-analysis. The meta-analysis says that there is no benefit. If the meta-analysis says there is no benefit, that means the strong evidence has led to a no recommendation. So the relationship is like that. It is not linear. Now coming to what are the benefits of evidence-based medicine. It improves quality and consistency. There is no doubt about it, because consistency is always there. Everyone will practice the same thing. So there is universal access to the best available treatment. So there is no confusion, total transparency. Patient can be easily, we can easily communicate to the patient what is the level of evidence, what is the guideline, and so the whole treatment process becomes very uniform all over the country or all over the world. It minimizes preventable errors. If we are given liberty to decide on every patient, each and every physician would like to treat the patient differently. Even in our practice, we may have somebody would like to do something, somebody would like to give general anesthesia, somebody would like to do this, that. So that thing will not be there, and there will be no error. It will reduce treatment cost. Definitely it reduces treatment cost, because otherwise what happens, for example, particularly in private hospitals, they will start with the worst kind of antibiotic, and they will ultimately land into a different antibiotic. So if there are guidelines, clear guidelines about antibiotics, they will have to use that particular antibiotic. Cost effectiveness of choice. Definitely it is cost effective choice. Patient will have a choice. Patient knows there will be clarity. Provide defensible framework. It is a defensible because there are evidence available, there are clear guidelines given by professional associations, so there is no issue of litigation. It enhances the professional confidence in us. We are confident, particularly if you have seen particularly for us anesthetists, the importance of what we are doing particularly in perioperative cardiovascular management of non-cardiac surgeries, totally based on evidence what we are doing. Everyone is following the same practice. It enables effective communication. Same thing, we can communicate to patient effectively with evidence available. Totally transparent delivery. This is one thing that I have prepared for a roadmap to evidence-based medicine, Indian Railways Health Service. Yesterday I talked to DG sir also regarding this in person. We need to, in railway hospitals, how do we implement evidence-based service, evidence-based medicine? Because we need some kind of driver for that. And that's why I propose that we should have introduction of NEBMS courses, DNB courses DNB courses or NMC courses wherever possible. We need to do this because we must have postgraduate student, and then only we'll have a culture of evidence-based practice. There should be an uniform policy for faculty management. Currently, we do not have any uniform policy. For example, in our hospital, we have only 33 doctors. So how do you expect that a specialist will be available here? It is not possible, because the Indian Railway Health Service, the whole cadre is designed for industrial medicine. It was never considered, this super specialty or specialty was never considered. So we need to have additional, if we want when we are implementing specialty services, we need special services. We need specialists. And how do you get specialists? This is the way to get specialists. We must have uniform residency policy. Currently, we do not have any residency policy. For example, Northern Railway Central Hospital pays something, we pay something else. Northern Railway Central Hospital has almost everywhere there is a senior resident. We do not have. So this kind of discrimination leads to, in fact, we need more senior resident because we have lesser number of doctors. There is huge discrepancy in railways, Indian railways. For example, in Northern Railway Central Hospital, there are 220 doctors, maybe, including the internist and all. In Central Hospital here, we have 35 or 36. We need to ensure e-books and journal access. This is one important thing we need to have. For example, in Central Hospital, we have recently bought the clinical key, and we have 300, 300 IDs available. So we will be distributing these IDs to even our all specialists or non-specialists, whoever, who are interested in whole zone. Because in hospital we will need 33. Rest of the IDs we can distribute to our doctors. These are, what I am saying is electronic library, and it has got books also. So what we need, this kind of access we need. Otherwise it is not possible. We are currently getting some little bit of, allowance, book allowance. Nobody is buying books. So I have requested DG sir, I wrote also that every railway hospital where there is NBMS course, we need to have an armed linkage. This linkage is available with all India medical sciences institutes everywhere. All AIIMS are having this connection, and many central government hospitals are having this connection because we do not have. So we need to have. Why should we spend money on the digital libraries when Ministry of Health is offering this benefit? We need to develop training modules. Definitely, without training modules, we will not be able to go ahead. We need to have audit also. We are having audits, but it is very premature. Thank you. Now we'll be summarizing. To summarize, we integrate. The evidence medicine is integration of evidence, whatever we have, the skill and preferences. This enables patient-centered decisions, provides reliable framework, essential for modern healthcare, and it addresses the accountability factor, which is now very important because this has become an issue. And in yesterday we had a lecture on legal aspect of clinical practice, where also it is very important. Thank you very much.
Thank you, Dr. Maheshwari.
Thank you, sir,
for your nice presentation. Definitely, the outcome will improve if you follow the evidence-based practice. For your information, I worked in Northern NF Railway Central Hospital from 89 to 93. Then again, I came here in 2010 for the RAISA conference. My memories are still intact. I never thought I will come again and talking to you people from this stage. Thank you.
Thank you, sir. This is a photograph we had in last conference in 2004, and three founding members are visible in this photograph. Thank you very much.
For the oration of Dr. B.N. Ghosh sir. Now I request Dr. Pramana Maheshwari sir to kindly felicitate our chairperson, Dr. M.C. Pawar sir, on the stage. Thank you, sir, for the great oration. First session of the day. To begin with, I would like to call upon stage our respected chairpersons, Dr. Chandrakant Patel sir, ACMS, Raipur South East Central Railway, and he is the immediate past secretary of RAISA. Sir, I welcome you on the stage. And I would also like to welcome on stage Dr. Vidyut Gogoi sir, radiologist, ACHT, Central Hospital, NFR, Maligaon. Sir, I request you to please come up on the stage and chair the speakers.
So we will begin today's scientific session with our first speaker, Dr. Geeta Devi ma'am. She completed her medical education at VSS Medical College, Bola from Odisha, and went on to earn her DMD from the Central Hospital, Maligaon. Following demonstrating a remarkable dedication to lifelong learning, she achieved her DMD degree at an age of 50 in her 50s, and which is an inspiring testament to her commitment to professional growth and excellence. With an illustrious career spanning over 28 years of time, she is currently serving as ACMS in East Coast Railways. Her vast experience and leadership has significantly contributed to the healthcare services in our railway sectors. Adding to her academic achievements, Dr. Devi was awarded the first prize for Best Poster Presentation at RAISACON 2022, reflecting her continued engagement with research and academic excellence. Her journey is truly inspiring, and her contribution to medicine and healthcare administration are commendable. And one more fact is that when I joined my first day for DNB in Central Hospital, her was last day of residency, so I couldn't get the experience of working with such a dedicated and hardworking person. We welcome you, ma'am.
Thank you, Aman, for the kind introduction. Respected chairpersons, my seniors, colleagues, juniors, and friends, a very good morning to you all. As already told by Aman, my years in service and age are long, but as an anesthesiologist, I'm still in my infancy. So if there's some mistake in this presentation, please forgive me. The topic that I have been given is perioperative fasting and feeding guidelines, and over the next few slides I'll be speaking about NPO, that is nil per os, its history, the significance behind NPO in relation to anesthesia, and the rationale behind it. Then what is meant by perioperative nutrition? How is it classified? The fasting as well as the feeding guidelines in different patient categories as instituted by the international anesthesia bodies, ASA, ESPEN and IAPA. The role of drugs and gastric ultrasound in the preoperative period and carbohydrate loading. Coming to clinical practice guidelines. What are they and why do we need them? Dr. Maheshwari has just enlightened us about practice, this evidence-based practice. So to define it, they are systematically developed recommendations which assist the clinicians and patients in decision making. And why are they done? It is to improve the quality, safety and consistency of care. And they are made based on the best evidence and expert consensus. They are not rigid rules and they are adaptable to the patient context as well as new evidence available. So as I said, why do we need them? The population all over the world has diverse food habits. They are not the same and this results to practice variability regarding to periop fasting. So a generic advice given is, please take a light diet 6 hours before. This may mean something different in different patient populations. Somebody might think that taking bread and butter is a light diet, but that contains fat, which has a delayed digestion, and this may lead to cancellation of operations, leading to patient dissatisfaction as well as for the difficulties for the doctors. So, as I told earlier, the guidelines have been formed by major international anesthesia bodies like American Society of Anesthesiologists, the Indian Society of Anesthesiologists and Indian Academy of Pediatric Anesthesiologists, the ESPEN, that is European Society of Nutrition, and the European Society of Anesthesiologists and Intensive Care. So coming to the definitions, the perioperative fasting is the restriction of any diet which can be solids or liquids before administration of anesthesia, which can be deep sedation, regional anesthesia or general anesthesia. So for how many hours we have to stop and which kind of diet has to be restricted, that is the perioperative fasting guideline. And what is perioperative feeding? It is the nutritional support that we give to the patient before a surgery as well as after the surgery. Coming to the history of NPO, it is very interesting. It has started as early as the year 1882 when Joseph Lister said that before administration of chloroform, it is desirable that there should be no solid matter in the stomach. But it is beneficial to the patient to give a cup of tea or beef tea about 2 hours previously. So as early as 1882, the importance of an empty stomach as well as adequate nutrition was given importance. So, but the real origin of nil per os or NPO after midnight as we know it, it started in obstetric anesthesia. In the year 1946, Dr. Curtis Lester Mendelsohn, who was an obstetrician, published a landmark study. He detailed 66 cases of aspiration of gastric contents during anesthesia among 44,016 pregnant women. And he hypothesized that if you keep a patient in prolonged fasting, then there will be no stomach contents which will prevent aspiration. And this will reduce aspiration pneumonitis during anesthesia. So, but that was then, and over the years, new evidence came that if you keep a patient on prolonged fasting, it will lead to metabolic stress, which will increase the stress hormones and increase the length of stay. So, slowly the guidelines evolved from meal per oral after midnight to evidence-based liberal fasting. What is the clinical rationale? We know that an empty stomach will prevent pulmonary aspiration as there are no stomach contents to be aspirated. But and adequate nutrition before fasting will reduce the metabolic stress, and this will improve the post-operative outcomes and reduce the morbidity. Regarding the risk of aspiration, this depends on the volume and the pH of the stomach contents at the time of administration of anesthesia. We all know that under deep sedation or anesthesia, the reflexes are abolished, and any contents which are aspirated are not able to, will straight go to the lungs and lead to aspiration. So if the volume of the stomach contents is more than 25 ml, or it contains solid food matter, or the pH of the contents is less than 2.5, then this increases the aspiration risk. As we can see from this graph, the emptying time from the gastric contents depends on the kind of food. The clear fluids of low caloric value take less than 2 hours to empty. Liquids with high caloric value and non-clear liquids take longer than 2 hours. A combination of liquids and solids take up to 4 to 7 hours. Breast milk takes approximately 4 hours, and fat-free solids take 6 to 8 hours. But when we come to fatty, fried solids, they can remain in the stomach for up to more than 10 hours. That is why fatty food should be avoided on the night before surgery. But what are the problems of traditional fasting? When we say that be NPO, and usually people think that NPO means you can take your last meal at around 10 o'clock and then you cannot take anything else. So the complications are, it can lead to dehydration, and dehydration will increase the risk of kidney damage, particularly if you are using some contrast dye for any investigation. It can lead to hypoglycemia, especially in diabetic patients, leading to dizziness, confusion, or fainting. If there is no adequate fasting, it can lead to delay, which due to complications arising from NPO, we will have the need to stabilize the glucose and then postpone the surgery. It can lead to electrolyte imbalances, and these can lead to arrhythmias and other complications. The patient will have discomfort from prolonged hunger, and it will increase the anxiety, thirst, irritability, and this impacts their cooperation during procedure, as well as it leads to morbidity and increased length of stay. So when we come to perioperative nutrition, how is it classified? It can be clear fluids, oral nutritional supplements, a light diet, a heavy diet, or parenteral nutrition. Then what do we mean by clear fluids? It can be water, clear tea, no milk, and coffee, that too without milk, fruit flavored drinks, and carbohydrate beverages or clear broths. Why do we need oral nutritional supplements? These are usually given in patients who do not have adequate, who cannot take adequate solid food, malnutrition, or having chronic diseases. And these are nutrient-dense formulae which need the energy and protein needs of the patient. When we talk of light diet, it means easily digestible food which is low in fat and fiber. And when we talk of heavy diet, it is a regular solid food that we eat with fat and fiber. And coming to parenteral nutrition, this is given intravenously, and this is given when oral or enteral feeding is not possible or insufficient, as in cancer patients or having gastrointestinal surgeries. So these are some of the guidelines evolved over the years. I'll not be going into detail. Now, these are the preoperative fasting and feeding recommendations, which are the latest ones. In adults, clear fluids can be taken up to 2 hours, and I have already described what clear fluids are. A light meal can be taken up to 6 hours before surgery. A fatty meal approximately 10 hours before surgery. It varies in other population like children, pregnancy, obesity, and bariatric. In children, clear fluids can be taken up to 2 hours, but in low-risk surgeries, it can be even up to 1 hour. Breast milk can be taken up to 4 hours, formula milk up to 6 hours, a light meal 6 hours, and fatty meal just as in adults up to 8 hours. In pregnancy, clear fluids 2 hours, light meal 6 hours, and fatty meal 10 hours. In obesity or bariatric patient, clear fluids up to 2 hours, light meal 6 hours, but fatty meals should be avoided. So, as mentioned earlier in the earlier slide, there are special populations in which the perioperative fasting and feeding guidelines have to have some special considerations. These are pregnancy, obesity and bariatric patients, diabetic patients and pediatric patients. So in obesity, usually obese individuals require longer NPO. This is because they have the increased gastric volume and the increased abdominal pressure. This leads to a higher risk of aspiration, which is exacerbated by abdominal obesity and its impact on the gastric pressure. In diabetics have gastroparesis. This causes delayed gastric emptying, and according to ASA guidelines, patients with diabetes may require longer fasting intervals. In the pediatric population, this is a special population because they have smaller stomach volumes, lesser reserves, and they cannot withstand very long fasting periods. So for them, it is clear fluids 2 hours, breast milk 4 hours, non-human milk or formula milk up to 6 hours, and food for 8 hours. So, as I said, I'll be touching upon a few medicines which we give as prophylaxis for aspiration. These are antiemetics like ondansetron and metoclopramide, non-particulate antacids like 10% sodium citrate, H2 receptor blockers like ranitidine and famotidine, PPIs like omeprazole and ramiprazole. These increase the pH of the gastric content so that even if there is aspiration, there is lesser risk of pneumonitis, and they reduce the severity of aspiration-related morbidity. The role of gastric ultrasound. It is a point of care modality which we can use to ensure that the patient is actually on an empty stomach. Because several times when we ask the patient or we advise the patient, that advice may not be followed. And if we have a doubt that it has not been followed, this can be followed up by a gastric ultrasound to access the stomach content volume. So this is to know whether patient is on empty or full stomach. It can be also seen in emergency cases and whether there is a fasting violation. But the limitations are that it is operator dependent and the availability is not there. And coming to carbohydrate loading in surgery, these are specially formulated clear fluids which are designed to shift the body from fasting state to anabolic state. They contain complex carbohydrates, especially maltodextrin, which is a complex glucose polymer, and it maintains a lower osmolarity, which allows for faster and more predictable gastric emptying. A 12.5% carbohydrate concentration is used and also contains electrolytes like sodium, potassium, and other micronutrients. So these are some common commercial examples, and according to ERAS protocol, there are two protocols. The evening before, 800 ml contains 100 gram carbs, loading dose, two packets in 400 ml of water, and in the morning 400 ml up to 2 hours before anesthesia. This places the body in a glycogen reserve state. Second protocol is the evening before surgery, to separate servings before bedtime. So this reduces the insulin resistance, which decreases the stress hormones, and thus there is decreased decreased incidence of infection, decreased length of stay, reduces anxiety and stress, and reduces protein loss. Improves the immune response, leading to faster recovery, improved patient care, supports the muscle strength, and preserves the lean body mass. So this is already covered. So coming to the last two slides. So when we talk of post-operative feeding recommendations, we recommend early oral intake, but it is as tolerated. results in lesser length of stay and fewer complications. So these recommendations are adults within hours of surgery, and initial feeding should be with clear fluids and slowly converted to a normal diet. In children, once they are awake, and they should be given clear fluids and see whether there is vomiting or not. In cesarean section, within 6 to 8 hours, from liquids to soft diet. In bariatric surgery, it should be early and cautious feeding with a caution that there should be no vomiting and low volume liquid should be started. So the take-home message is that we have to shift from traditional prolonged fasting towards patient-centric evidence-based care, which is essential for optimizing perioperative outcomes and enhancing the quality of surgical care. Thank you.
Thank you, ma'am, for your nice and elaborate presentation. I have a small query here. Is there any difference or additional guideline regarding the types of major surgeries, say surgeries where the surgeon need less time, and in surgeries where surgeons need very long time, like a cancer surgery or brain tumor surgery? Is there any difference, or is there any additional points, or depending on say surgery of brain or surgery in the gastrointestinal tract, and depending on whether you have mentioned that it is necessary in case of general anesthesia as well as in regional anesthesia also. So kindly put some light.
The pre-operative fasting guidelines remain the same, that we have to keep the patient adequately nourished, and whatever the length of surgery, the intra-op requirements have to be taken care of within the operative period. So that differs from patient to from surgery to surgery, but the pre-op requirements remain the same.
Regarding, sir, you asked about the regional anesthesia. Is not necessarily that the surgery is going to be completed within that regional anesthesia time period, and in some cases or many cases it has to be converted into general anesthesia. So once we are going for the surgery, the pre-op guideline has to be adhered to, so that patient should not have any trouble if we convert from regional to general anesthesia. So we take that as a standard to keep that patient pre-op fasting, like madam has advised. So there is no difference if it is concluding within half an hour or 4 hours or 8 hours or 12 hours. Ji, that is there, sir. Yeah. Thank you, Dr. Geeta, for a very refreshing topic. Thank you. We will take questions after that session, which is related to the pre-op or perioperative medications and fasting.
Thank you, ma'am, for your insightful knowledge. I now call upon our next speaker, Dr. Monali Thakur ma'am. She completed her MBBS and diploma from Guwahati Medical College and followed by her DNB from Central Hospital, Malegaon. She further gained her clinical experience while serving as senior resident from Guwahati Medical College. Currently, she is working as a consultant intensivist at BPCI Hospital, which is a unit of Tata Memorial Center. In her role, she is actively involved in managing critical ill patients and contributing to high quality of intensive care. While with her strong academic background and extensive clinical experience, she brings valuable insights into the field of critical care. Please join us for warmly welcoming Dr. Monali Thakur ma'am.
Thank you, Aman, for your warm introduction. Good morning, everyone, respected chairpersons, distinguished faculty, my colleagues and juniors. I'm Dr. Monali Thakur. As Aman has introduced, I have done my secondary DNB from Central Hospital, Malegaon. And so I'm very thankful for giving me the opportunity to speak on a topic today. The topic that I was given is perioperative medication management. So today I'll be discussing on what medications to stop, what to continue, and what to rethink. Let us first assume a case, a patient who is a 62-year-old male who has comorbidities like hypertension, coronary artery disease, drug-eluting stent was administered 1 year ago, and he is a CKD stage 3, and he is currently on the following medications: aspirin, clopidogrel, metoprolol, telmisartan, empagliflozin, and apixaban. So how will you approach this case? What are the medication will ask the patient to stop? What to continue? We'll come back to this slide again. First, let me introduce the topic. Perioperative medication management, it's an integral part of surgical care, because frequently we encounter patients on medications for any acute or chronic illnesses. At least 50% of the patients undergoing surgery, they are on regular basis on some kind of medication or the other. And the management of these medications perioperatively, it involves a systemic evaluation, continuation, modification, or temporary discontinuation of the medications. Our primary goal during this management is to balance the risk of these medications against the risk of interrupting essential therapies in the perioperative period. So there are certain principles which should guide our perioperative management. First, a very detailed history should be taken and a multidisciplinary approach to review. We need to address the accuracy of the doses and then verify whether the patient is getting accurate dose or not. And medications to be included are all kinds of medications to be included, like the over-the-counter medications, herbal medications, prescription drugs, as well as substance abuse information. And as we all know that gastrointestinal absorption of oral medications may be impaired due to changes in the splenic blood flow and edema during surgery and also post-operatively. So as far as possible, oral medicines to be substituted with alternate parenteral route during the immediate post-op period. And also timely post-operative resumption of the medications to be done to minimize complications. I'll discuss the very frequently encountered medications system-wise. Like coming to CVS medications, we usually encounter patients with beta blockers, alpha-2 agonists, calcium channel blockers, ACE inhibitors, angiotensin receptor blockers, diuretics, non-statin hypolipidemic agents, statins, digoxin, etc. So individually, like beta blockers, if a patient is taking, we'll ask the patient to continue, including on the day of surgery, because it will prevent arrhythmias and also post-operative MI. There is post-operative MI. If the patient is having a post-operative MI risk, high risk, then also we will ask the patient to continue. Then alpha-2 agonists like clonidine can also be continued, but those drugs are not initiated in the immediate preoperative period. If the patient is already taking those medications, we'll ask the patient to continue. Calcium channel blockers can be continued. ACE inhibitors and angiotensin receptor blockers, there are chances of refractory hypotension if the patient is continually taking this medication. So we ask the patient to withhold these medication on the particular day of surgery. Diuretics can be continued if a patient is a known case of heart failure, otherwise can be stopped. Then non-statin hypolipidemic agents should be discontinued a day before surgery, because there are some certain studies which say they might cause rhabdomyolysis or myopathy. Statins and digoxin can be continued. Coming to GI medications, H2 blockers or proton pump inhibitors, they have to be continued, preferably in the IV formulation, because it will reduce the stress-related mucosal damage and it decreases the gastric volume. And coming to pulmonary agent, a patient who is having COPD, asthma, or any pulmonary comorbidity might be taking inhaled bronchodilators or theophylline or leukotriene inhibitors like montelukast. The inhaled bronchodilators and leukotriene inhibitors to be continued because it will reduce the post-operative pulmonary complications. But theophylline has a very narrow therapeutic range, so we asked to patient to discontinue the evening before the surgery. Then endocrinal agents, glucocorticoids, then thyroxine sodium, anti-thyroid medications like methimazole, carbimazole, all these drugs to be continued to prevent myxedema coma or to prevent thyroid storm. Coming to oral hypoglycemic agents, to very new developments. Earlier we used to stop all hypoglycemic agents on the day of surgery, but the latest guideline says that sodium glucose co-transporter 2 inhibitors, that is SGLT2 inhibitors, example dapagliflozin, canagliflozin, empagliflozin, these drugs to be stopped 3 to 4 days prior to surgery because these drugs are known to cause euglycemic diabetic ketoacidosis. Also, glucagon-like peptide 1 in a receptor agonist like Ozempic, Monjaro. If the patient is taking once weekly dosing, then the week before the OT, that dose should be skipped. Or if the patient is taking daily dosing, then before the elective procedure, the day before the elective procedure, these drugs should be stopped because these are known to delay the gastric emptying, and so there is chances of aspiration. All other OHs to be stopped on the day of surgery. Basal insulin can be continued at 75 to 80% of the usual dose, and also intraoperative insulin infusion can be used. So this is the same thing that I have already discussed. These particular drugs to be stopped 3 to 4 days prior to reduce the euglycemic ketoacidosis. Especially in cases of fasting, low carbohydrate intake previously, acute illnesses, or in volume depletion states, there are chances of these drugs causing ketoacidosis. Supposedly a patient has come and for an emergency surgery and patient GLP-1 agonist were not withheld before the surgery, then we need to do a gastric ultrasound and then see for the stomach contents. If it is inconclusive, then we should go for a RSI, or if possible delay the case. And if the gastric contents are stomach is empty, then we can proceed normally as normal general anesthesia. Coming to oral contraceptives and postmenopausal hormonal therapy, if the surgery is if in the surgery there is low to moderate risk of venous thromboembolism, then we can continue without interruption. But in case of high risk surgeries for thromboembolism, then we need to stop oral contraceptives and postmenopausal hormone therapy at least 4 to 2 weeks before surgery. Another thing is, if you are using Sugama-Dex as reversal agent and the patient is taking oral contraceptives for patient taking oral contraceptions, then we must ask the patient to adopt alternate form of contraception for at least a period of 7 days, because there is chances of contraception failure when we are using Sugama-Dex. Coming to anticoagulants, I am just going through the major updates. So recent guidelines say that risk stratified interruption is better than a routine bridging. So coming to direct oral anticoagulants like apixaban, rivaroxaban, dabigatran, these drugs to be stopped 24 to 48 hours before a low bleeding risk surgery, or if it's a high bleeding risk surgery, then it needs to be stopped 48 to 72 hours. Bridging with heparin is usually not recommended nowadays. Reversal agents are available for these drugs, idarucizumab, andexanet alpha, although I am not sure about the availability of the drugs now. Then warfarin needs to be stopped 5 days before surgery. And then bridging is required only in high thromboembolic risk cases like patient with mechanical valves or recent history of stroke. And bridging drug is low molecular weight heparin like enoxaparin. Antiplatelet therapies like aspirin, clopidogrel or ticagrelor. We continue aspirin in most of the cases. Then clopidogrel and ticagrelor are stopped 5 days prior to surgery. This is a chart which is showing like ticagrelor is stopped around 3 days prior to surgery, clopidogrel 5 days, prasugrel around 7 days. Some studies say that we can do bridging with cangrelor, but not all studies support this bridging with cangrelor. Psychotropic agents, antipsychotics, benzodiazepines to be continued even on the day of surgery. Mood stabilizers like lithium and valproates can also be continued, but with close monitoring of electrolytes. Then monoamine oxidase inhibitors. These drugs actually, if you use adrenaline in presence of these drugs, then it can cause severe hypertension. And or if you use meperidine, then it can cause serotonin syndrome. So if you are not using these particular drugs during the surgery, we can ask the patient to continue, but otherwise it is better safe to stop 2 weeks prior to surgery. Serotonin reuptake inhibitors, they increase the risk of bleeding, so we need to discontinue 3 weeks prior to surgery. Tricyclic antidepressants, their risk of causing arrhythmias, but also abrupt withdrawal can lead to insomnia, nausea, headache, severe salivation, and increased sweating. So we will ask the patient to continue, including on the day of surgery, for patients with high doses. But patients on low doses, plus there is a risk of perioperative arrhythmia, so we ask the patient to discontinue 7 days prior to surgery. Hyperinsomnia drugs, we can continue allopurinol, but cautiously to be stopped on the morning of surgery because it can cause muscle weakness and polyneuropathy. Herbal medications, these are some of the herbal medications we commonly encounter, like ephedra. There's chances of MI and stroke, so we discontinue 24 hours prior to surgery. Garlic to stop 7 days prior, theoretically. Actually, I'm not sure how possible it is to ask the patient to stop garlic. But then there's the study who says that it increases the bleeding risk. Ginkgo biloba also increases bleeding risk, so we need to stop 36 hours prior. Ginseng lowers blood sugar, so it has to be stopped 7 days prior. Kava, it increases the sedative effect of anesthetic, so it will be stopped 24 hours prior. St. John's wort, it induces cytochrome P40 enzyme, so to be stopped 5 days prior. Miscellaneous category drugs like antiretroviral agents, then medications for benign prostatic hyperplasia, or any neurological agents for like anti-epileptic, Parkinson's disease, dementia, all these medications are required to be continued. So we can finally come to a conclusion that perioperative medication management, it remains a cornerstone of perioperative care, reducing discrepancies and preventable complications. And the decisions regarding discontinuation and reinstitution of drugs must consider the pharmacokinetics, surgical bleeding risk, and patient comorbidities. Coming back to my first slide, so now we are almost clear which drugs to stop, which drugs to continue. Aspirin can be continued. Clopidogrel 5 days prior to surgery will stop. Metoprolol to be continued. Telmisartan to be stopped on the day of surgery. Empagliflozin to be stopped 3 to 4 days prior to surgery. Apixaban, depending on whether it's a high bleeding surgery or low bleeding, we need to stop 48 to 72 hours prior to surgery. So finally, I would like to give a take-home message, which includes 5 golden rules, that is, to continue the cardioprotective medications, stop GLP-1, SGLT2 inhibitors early, then we need to individualize anticoagulation therapies depending on what kind of surgery the patient is undergoing or what cardiac risk it holds. Then we need to assess bleeding versus thrombotic risk, and we should communicate with the surgeon and the cardiologist because it has to be a multidisciplinary approach, not a single-handed approach. Thank you.
Thank you, Dr. Monali. You have presented nicely. So again, a general question from my side. You have already mentioned that it is a multidisciplinary decision, but can an anesthesiologist give fitness in all cases before surgery, or what are the case scenarios or conditions you need to help from another department? And in your personal experience, what is the most direct condition you hesitate to give a fitness? Is there any medical legal issue?
So actually, fitness, the ultimate fitness for surgery and anesthesia is to begin by an anesthetist only. We approach the other departments, because we need to know their perspective on what basis they're starting the medication, what are the risks that can happen. But ultimately, it is on us, because we will be knowing what are the anesthetic medications we'll be using. So what are the side effects of these drugs? What more harm can the drug do to the already existing conditions? So it's an approach. We should consult everyone, but then finally, only the anesthetist who is going to administer the anesthesia to that particular patient, he or she will be deciding the fitness actually. Because if somebody else is also administering the anesthesia, he or she also should be doing the PAC by himself only, because somebody else's fitness certificate is not enough for that person to know. So,
thank you, doctor, for the nice elaboration on this perioperative medication. Thank you. Any question from the audience, please? Any question? Yeah, please hand over a mic. Sir, please speak on mic, sir.
If a patient who is already on GLP-1 or SGLT2 inhibitors, if they might encounter for some surgical emergency, what do you do in that case?
So if the patient is taking GLP-1 then we will do a gastric ultrasound, because it's an emergency case, so we cannot wait for time period. Then we have to do a gastric ultrasound, and if we see that gastric content is there, we'll go for a rapid circuit intubation. And if it is inconclusive also, then also we'll go for rapid circuit intubation. And if we see that gastric contents are minimal or no, then we can go for normally how we go for a general anesthesia. If it's a general anesthesia case, then just like that only. And for SGLT2 inhibitors, in that case, we can keep a track of the sugar levels, and then ketone bodies also we can measure. And then if there's any ketoacidosis, that can be managed intra-op also, by looking at the ABG and all. We have to manage like that.
Thank you. 5 days before, 5 days.
Sir? In case of an emergency, sir.
Thank you, ma'am.
Thank you, doctor. You can move further.
Thank you.
Thank you, Monaliba, for your short and informative topic. Now, with this presentation on perioperative medication management, we come to the end of this session. I would request our respected chairpersons, Dr. C.R. Patel sir and Dr. Bidut Gogoi sir, to please proceed to the podium for the felicitation ceremony. And I request our speakers, Dr. Geeta ma'am and Dr. Monali ma'am, to please proceed to the podium for the felicitation ceremony. And I request our chairpersons to please felicitate our speakers at the podium. And I request Dr. Madhav ma'am to please felicitate our respected chairpersons. So now we are ready to begin with our second session of the day. To chair our second session, I would like to call upon stage Dr. Srabani Basu ma'am, MBBS DGO MD Anesthesia. Ma'am has retired as ACHD and HOD of Anesthesia and Surgical ICU and has been president of RAISA in 2019, and ma'am has raised RAISA to new heights. I would like to call upon stage Dr. Srabani Basu ma'am as the chairperson. Also, I would like to call upon stage Dr. Chunki Datta ma'am. She is a retired ACHD from DR Singh Eastern Railway Hospital. She is an anesthesiologist and an intensivist. She is a present faculty for DNB Emergency Medical Course at Manipal Hospital, Kolkata, and is a past RAISA member. Also, I would like to call upon stage Dr. B.P. Daka sir, eminent physician and medical director at Central Hospital, NFR, Maligaon. I request all our chairpersons to please come up on the stage and chair over the next session. Thank you, sir. Thank you, ma'am. I would like to call upon stage our next speaker, Dr. Swajit Giri, sir. He is a consultant anesthesiologist at National Health Mission, Government of Assam, India. Sir is a field expert in National Action Plan in snakebite envenoming. He is a certified master trainer of Government of Assam for the Doctors of Assam and is a snakebite social activist. I request Dr. Surojit, sir, to please take up on the stage and proceed.
Thank you, sir. Good morning, ladies and gentlemen, and respected chairperson. So in half an hour, we are going to discuss about a very important topic that is called the acute emergencies of FORE. So actually, these people are, I don't know. Yes, I did. So these snakes and snake bites, this is actually happening in the rural area, but luckily or unluckily, because of the global environment and the changes in the environmental scenario, it is going to be an urban problem. So yesterday it was a rural problem, but now the snakes are found in the 5th floor, 6th floor, even in the 10th floor. So we have to be get ready for these environmental changes. I declare that I have taken written consent from the patient and the parents for photography and videography, and I thanks my snake rescuer of the Assam for giving me the input on different snakes of Assam. Now, ladies and gentlemen, this is a patient at bite that is around, not in snake actually, she have not seen the snake, and it was an inside home bite. It is an unknown bite. It was around 12:30 p.m. and hospital admitted within 1 hour, almost around 1:40, and patient has severe pain. There is a swelling, and there is a color changes, and there is a tourniquet, and there is a multiple episode of vomiting. So, what is your approach, ladies and gentlemen? May I request any one of you, what is your approach in this patient? It is an unknown bite. Excuse me? How you came to know it is a snake bite? No, there is only vomiting. Patient is conscious, oriented, responding. Patient has pain, swelling, and color changes. These things are happening. So there is no neurotoxicity at all. Fang marks are there. Excuse me? Fang marks are there. So fang marks has no value in snake bite management. Anybody? Okay, let's find it. So this patient attended within 1 hour in our hospital. Why? Because previously snake bite means fate healer and then comes to the hospital. So from 2018, we have started a model in our hospital that is a novel model in snakebite management, participating the communities. So first we trained our communities. We selected one person from the communities that is called a venom response team. So he will inform us that there is a snakebite is happening, and he will transfer the patient to the hospital. Okay. Then we have formed a WhatsApp group with the venom response team. So he will sometimes upload the photo of the snake bite victim, sometimes the bite mark, sometimes the snake photo, etc. Okay, so we have a direct communication with the communities. Then we have converted a room to a snake bite treatment room so that the medicines and the things will be organized. And then we have trained our staff that is called a fast response team. So these are the people who will identify the danger sign. Once there is a danger sign, they will immediately infuse antivenom or neostigmin like that, and patient will be survived. Now the impact of this model is that, see, in 2018, the snake bite to the hospital admission time was around 300 minutes. So patient went to the fate healer and then came to the hospital. Now it is reduced to 25 minutes to 30 minutes from 2022 onwards. So we have bypassed the fate healer and patient are attending to the hospital. So this is the model which we are running in from 2018 in our hospital or in the communities. Now that hospital, another hospital, this patient attended, doctor has given the tetanus, diclofenac for pain for the patient has vomiting, patient has given the on them, he immediately removed the tourniquet and after 10 minutes patient died. Why? Any reason? Kile morile? Electrolyte imbalance. Okay. Anybody? Okay. So we have to know in the demo hospital this patient was treated, immediately given the 20 vials of ASB immediately without checking the pulse BP. Immediately the antivenom was injected. Patient after injecting the antivenom, after 15 minutes tourniquet was removed, patient survived and sees the patient. What happened? half I thought there are snakes around. So okay, no. So this is the patient. She survived. So why? Because this staff, the nursing staff has treated that patient. Why? You can see, because our nursing staff are experienced of treating 3,563 patients. And there was venomous rate was around 511 patients, and only 3 patients required ICU. So ICU is not mandatory for snake bite management. Date was only 1, that is in 2020, and venomous rate is only 14%. And you can see around 800 to 600 numbers of the patients are attending per year to our hospital, and that is why they are experienced enough this treating this victim and practically. Now, this is the protocol we follow. Patient has unknown bite, patient coming with an unknown bite, no systemic symptom, wait and observe. Patient has unknown bite, progressive pain and swelling, vomiting is there, it is an cobra, inject antivenom. And snake has been seen, and if there is a progressive pain and swelling, you should infuse the antivenom because it is a cobra. So in this victim, there is a pain, progressive swelling, vomiting is there, it is a cobra, infused antivenom, that's all. So that is why patient survived. Now progressive pain and swelling in Assam or in any of our India, you can see there is a possibility, 2 things, there is a viper and the cobra possibilities. Now in our area, we have pit viper and Russell viper in some of the district. And if there is no systemic symptom, then it is a pit viper. If there is a vomiting, early sign and symptom is there, then it is a cobra, and in the Russell viper zone, it is a Russell viper. Okay, so infuse the antivenom. Now these are the indication of anti-snake venom. All patients does not require anti-snake venom. Now we have added one, this is the last point. Confirm photo of the crate is available. Patient is taking a photo of this snake photo and it is a crate, and even then patient has no sign and symptom. Infuse antivenom because crate venom is a presynaptic blocker. Once it causes neurotoxicity, most of the time it requires tracheal intubation and ventilation, especially if you do not have any ICU. You infuse antivenom, even then there is no symptom. Now blunders one, what we are doing, you are removing the tourniquet, we are not following the protocols. So these are the 5 rules in the tourniquet removal. You have to remember duration. If it is more than 1 hour, be careful. Second, contraindications, absolute contraindication. If the patient, suppose there is a tourniquet, distally you are not getting any radial pulses, do not remove if you do not have any multidisciplinary team. Immediately patient may require resuscitation or intubation after removing the tourniquet. Now patient should be in the supine position in tourniquet removal. Then you have to use the BP cuff to release the tourniquet, and after release of tourniquet, monitor and reassess the patient at least for 1 hour. Now this is how we follow in the tourniquet removal. So if it is a pale limb, not peripheral pulses not present, we do not release the tourniquet in our community health center because we do not have any multidisciplinary team. Now if it is greater than 1 hour, be careful. Peripheral pulses is present, patient should be supine position like this. This is the tourniquet. we proximally apply the blood pressure cuff. And suppose the patient blood pressure is 130, we increase the blood pressure up to 140 and hold the cuff like this. We do not release the cuff. Then only we release the tourniquet. But again, if you are suspecting a venomous bite, that patient, that lady who came with a severe pain, swelling, vomiting, we have identified this is a cobra bite. We are not going to remove the tourniquet. Immediately we will infuse the antivenom. So this antivenom will load the patient blood with an antivenom, and once we release the tourniquet, the venom will goes into the circulation, and that antivenom will fight with the venom present in the circulation, and patient will be survived. So these rules you have to follow in tourniquet removal. So even in the non-venomous bite also, there is a possibility of collapse and death after releasing the tourniquet if you do not follow the protocol, because distal to the tourniquet, patient may have metabolic acidosis, patient may have hyperkalemia, hypothermia and hypotension. Once you release these metabolites, it will go directly to the circulation, that is in the central circulation, and patient will have cardiac arrest and death. Every anesthesiologist that is facing in the orthopedic cases, you have this one experiences about the tourniquet management. Now this is the boy, 26-year boy, night-time bite, and 9:30 p.m. there is a bite. There is no pain, no swelling. Within half an hour he attended district hospital. Okay, and then you definitely put the patient for observation because it is an unknown bite, is not it? There is no pain, no swelling, no symptom, and you observe the patient. But after 2 hours, patient develop pain abdomen. Okay, whenever there is a night bite, always think that it may be a crate bite. Nighttime bite, no pain, swelling, possibility of crate. Now crate causes early symptom, that is a pain abdomen. Okay, so if you miss this pain abdomen, then patient will go into the neurotoxicities. Now when the patient developed the pain abdomen, he thought that it is an gastric. There is a possible more duty to if I am in the duty also, I think it is an gastritis because patient is on the alcohol effect. So I will give the pantoprazole, sucralfate, whatever it is. Okay, so he have given the pantoprazole and sucralfate. But what he did not monitor the patient. So he have to assess the patient after 1 hour or half an hour. If it is a gastritis, it should decrease or it should be relieved. But if it is not decreasing, not relieved, nighttime bite, no pain, no swelling, it is a crate bite, ladies and gentlemen. This is the early sign and symptom. Now this we have to infuse the antivenom at this moment. Now if you miss this, then patient will go into neurotoxicity. By 3 a.m., patient developed ptosis and neuromuscular blockade, and patient was given at that moment antivenom. Patient died. Okay, so this patient could have been saved, but we missed the early symptom. So these are the early symptoms. Never miss the early symptoms of snake bite, snake envenomation. We have published this. That is the stage 1, stage 2 and stage 3 of early symptom. So as the patient are attending in our hospital within half an hour or 1 hour, so we are injecting antivenom in stage 1 and stage 2, and as we are injecting antivenom at stage 1 and stage 2, we are preventing the tracheal intubation and ventilation. We are preventing the respiratory paralysis. Now patient coming with this in a casualty room after a snake bite, do not look after anything. This is an acute emergency, throat congestion. So you have to give the neostigmine atropine and then antivenom. Okay. Now this patient is bitten 3 times by cobra. You can see the broken neck sign. This is the broken neck sign, neck muscle paralyzed, ptosis, everything was there. So venom response team informed us, sir, snake bite is happening. I am sending the patient. He have uploaded the photo. It is a cobra bite. I have seen the patient and there is just mild pain. I have not infused the antivenom, so I put the patient for observation. But after 1 hour, patient develops severe dizziness and blurring of vision. That is the early symptom. And who identified that? That is the fast response team. That is our staff. They told that whenever the patient developed these symptoms, dizziness and this blurring of vision, immediately they have injected the neostigmine atropine and then 20 vials of antivenom. Patient slowly recovered. Why? Because cobra and the crate venom, they will cause descending paralysis. Once it will first attacks on the cranial nerve, slowly it will cause the bulbar paralysis, then the intercostal muscle, then the diaphragm. Now in this moment when it attacks in the cranial nerves, it will cause the early symptom like dysarthria, dysphonia, okay, and then ptosis, and then dizziness, and then this one blurring of vision. So at that moment we are giving this all medication, patient survive. You see, we have not given the oxygen, but you can monitor, you can see that she can hold the neck. So means we have reversed the neuromuscular block. So number 3 is that in the neurotoxicity, suppose patient having the neurotoxicity, you are keep on giving 20 vials, 30 vials, 50 vials, 60 vials, patient is not improving. So this is a blunder, ladies and gentlemen. Max to max 25 vials, not more than that. So if patient is, we have given the neostigmine, atropine and antivenom, and patient improved, then cobra. See, cobra, there is a dramatic improvement with neostigmine. If there is no improvement in the neurotoxicity after 3 doses of neostigmine, then think it is a crate. So you have to give this ambubec assistance, and then we shift the patient to nearby ICU because we do not have any ICU. Then we intubate, ventilate, and then again extubate after 2 to 3 days. So this is how we are using. There is myopyrrolate injection. You all know, for 50 kg 5 ml loading dose followed by 1 ml IV at 30-minute interval, and this is the maximum we can give 5 doses. So diluting fluid, normal saline 300 ml NS, children for 5 to 10 ml per kg. Rate of infusion is 20 to 30 minutes, sometimes in Z. So this is the this is the nerve, this is the muscle, this is the neuromuscular junction. Cobra venom works here, that is in the postsynaptic junction. Now if you inject the neostigmine, it will inhibit the acetylcholinesterase. Once it will inhibit the acetylcholinesterase, the acetylcholine will be abundant in the neuromuscular junction. It will displaces the venom from the neuromuscular block, and patient will have dramatic improvement. But in the crate, it will enters in the, this is presynaptic area, and they will destroy this presynaptic granules where the acetylcholine is there. Now there will be acetylcholine dry up in the neuromuscular block, and patient will not improve with the antivenom or neostigmine. So there is no role of neostigmine in crate bite. So you have to give the calcium, because calcium helps in the endocytosis of the granules and helps in the release of the calcium, acetylcholine, and improves the neuromuscular block. Now vipers of the Assam, there are 2 vipers. There is a pit vipers and the Russell viper. Russell viper only in the Bongaigaon, Sirang, and the Tezpur, Biguri area. So we have to think about the regional strategies that we have already given to the government of India, that we should have regional. There should not be any pan-India guidelines. There is the guidelines for the Karnataka will be something different. Guidelines for the Assam is something different. Even in the Assam, we have different type of venomous snake. So big blunder is that we do not have any big 4. These are called a big 4. We have this troublesome 6. This is called a Trimorosaurus species. This is called a pit viper, which causes coagulopathy. This is called a Naja Corthia. This is cobra, which causes the neurotoxicity. And these 2 snakes, Bungarus fasciatus and lividus. So these are only active in the night time, and these 2 snakes does not causes any local symptom. That is, the crate does not causes local symptom. So do not fool by the bite mark. So only the killer machine in Assam is the Naja Corthia, that is the cobra. Now types of the venomous snakes: viper, there is a pit viper in Assam, and that is the Russell viper in some of the places. Elapid bite is the cobra and the crate. Colubrid bite is the redneck killback. Now trends in the cases in the Assam, you see, Upper Assam, the most common bite is the pit viper, then followed by cobra. Mid Assam cobra, Lower Assam cobra, Barak Valley is the pit viper, then cobra. Cobra is omnipresent, whether it is in the first position or in the second position. So cobra is omnipresent. This is Russell viper, and this is pit vipers of Assam, and these are few of the pit vipers that is available in Assam. Now blunder 5, we are not doing the 20-minute whole blood clot test in a glass test tube. Okay, it should not be in the syringe. It should be fresh test tube. You take the 2 ml blood and take in the fresh test tube. It should not be washed. Okay, and it should be glass test tube. Put in the glass test tube. Wait for the 20 minutes. Exactly at 20 minutes till the glass test tube. Now, if it is clotted, means it may be non-venomous, it may be crate, it may be cobra. So cobra and the crate, the blood will be clotted. Only in viper, blood is not clotted, and in case of Upper Assam, it is in pit viper. In case of Lower Assam, it may be a Russell viper. So you have to think about where we are working. So 20-minute whole blood clot test in Russell viper zone, especially in the Bongaigaon, Sirang, and the Tezpur, you have to do 1 hourly for first 4 hours, then 6 hourly. If it is not positive, means it is not clotted, then infuse the antivenom. In non-Russell viper area, in case of our area, so we do in the on admission and whenever required. So in case of pit viper, there is no role of antivenom because there is no antivenom available in India which will work against the pit vipers. So we follow these protocols, demo protocol. Now this pit viper venom spontaneously it recovers within around 6 to 10 days. So we have to keep the patient very immobile. There should not be any trauma. Any invasive procedures should be abandoned. It should not be done whenever it is required. Then only we do. Even if we do not do the cannulation, if there is a cannulation, then we remove after 7 to 8 days. It does not cause spontaneous bleeding, but if there is a trauma, then he will not going to survive, ladies and gentlemen, because INR is almost around 100 or 120 like that. So you have to avoid that trivial trauma to the victim. There is no antivenom currently in India. So this is what blunders we are doing. We are keep giving the antivenom to the pit viper victims. There is no role. This will, it is said primum non nocere, means first do no harm to the patient. We know it is a pit viper. There is no antivenom available in the pit viper. Please do not give the antivenom because it will cause some reaction, dreaded reaction. So this is Russell paper bite data in Assam, 11 numbers of confirmed bite, 2 deaths. And big blunders we are doing that we are still using the 10 vials as a state dose because the national guideline says you give 10 vials, wait, if there is no improvement, give 10 vials. In a community health center where the only one doctor is available, 2 to 3 sisters are there at the 2 p.m. or at 10 p.m. patient comes, we need an immediate improvement because we do not have any ICU, we do not have any 24/7 anesthesiologists, we do not have any intubation facilities. So we have to neutralize the venom at the earliest. So if you see, antivenoms are against the naja, we have naja coatia. Antivenom are against the Bungarus ceruleus, we have Bungarus fasciatus, we have Bungarus niger and lividus. Antivenom are against Russell viper, we do not have any Russell viper except few districts. Antivenom are against the Echis carinatus, we do not have any Echis carinatus. Means we are in a state where there is no specific antivenom. But how do we are getting the results? Before 2018, we have started the 10 vials plus 10 vials. Patient went into intubation, patient died. But from 2018, we have stopped using the 10 vials. We will increase the dose to 20 vials. Same thing. Indian guidelines and 10 plus 10, we are saying we are giving 20 at a state dose. We are increasing the dose because we have analyzed the venom in the Tezpur universities, where we have given the lesser numbers of the antivenom, it did not neutralize. But once you increase the dose, it effectively neutralize the venom of the naja coatia. So this is our guideline already Assam government has published, thanks to Honorable CM sir, and where we have already mentioned that is 20 vials of ASB concept and there is no ASB for pit viper coagulopathy patient. So in the year 2025, we have 27 numbers of the death in Assam. You can see cobra bite, omnipresent, cobra bite having 19 numbers of the patient. You can see, observe, this is the 19 numbers of the patient died because of the cobra bite. But cobra always says, doctor, I am a cobra, identify me, identify symptoms. If you miss this early symptom, I am going to kill you, your victim. He always says, I am a cobra, identify me and treat at the earliest. Why? This patient, you can see 9:30 a.m. bite, then patient was presented with just mild pain. I have not injected antivenom. Patient develops increasing pain and swelling. I have not injected. Patient developed mild blackening in the bite area. I have not injected. Patient developed pain, abdomen, vomiting. I have given envancetone, pantoprazole, etc. I have not injected antivenom. See? And later patient developed the neurotoxicity. Why we are waiting for the neurotoxicity? Patient has these all symptoms. Patient is telling us from 9:30 a.m. to 1 p.m. he is telling me that I am a cobra, but I am not giving the antivenom. Why? Patient definitely goes into the neurotoxicity. So identify these symptoms and then give antivenom at that moment. Wrong way of handling neurotoxicity. We are giving lots of antivenom, but we are not giving neostigmine. Patient will definitely going to die. Now this patient was bitten by a cobra. See, patient is in a crisis. So at this moment we need an ambubag ventilation because the intercostal muscle is paralyzed. Next you give the neostigmine atropine. Next you give the antivenom. But our doctors and the nurses are running after the antivenom because we are taught like that. Whenever the patient develops this type of neurotoxicity, go for the antivenom. No, we think about assess the patient. If the patient in the crisis, Ambubac ventilation, neostigmine atropine, and lastly the antivenoms. So patient died. This is not from my hospital, but from the different hospital. So this is again from my hospital. So patient developed the established neurotoxicity. Patient developed the dysarthria. Dysarthria. Patient not able to speak properly. So our nurses immediately injected the myopyrrolate injection, that is the neostigmine and atropine. Immediately patient improved. Before giving the antivenom, patient recovered. Because whenever the patient has neurotoxicity, established neurotoxicity, first drug is the neostigmine atropine. Then only think about the antivenom, because antivenom will that is neutralizes the venom present in the circulation. But what the venom already attaches to the neuromuscular block, you have to reverse with a neostigmine atropine. So blunder 9, medicines are not organized. Whenever the patient comes, adrenaline are expired, ASBs are expired. We heard this type of things, and the solution is the snake bite treatment room, and this is what we always advise to keep these all medications. Now this patient, you can see, this patient was given 50 vial of antivenom, oxygen also given. And patient was coming, attended hospital in a smiling face, and he has given the antivenom. He has removed the tourniquet. Immediately patient went into a crisis. Now the approach should be Ambubac assistance, neostigmine atropine, lastly the antivenom. They have 50 vials of antivenom, but patient died because they failed to inject the neostigmine atropine. They have failed to assist the airway. Any crisis, always remember A, B, and C: airway, breathing, and circulation. So then we thought of expanding these protocols to all over Assam, and he is our state nodal officer, Dr. Loskar. We have talked to the government of Assam. We have trained our 2,500 of the doctors, and you can see the result. You can see the result. This is the BPSC. Co-provide. Patient in the crisis, Ambubac assistance, neostigmine atropine, 20 vials of antivenom, patient recovered. This is BPSC. This is again in the Tezpur. This is Orang CSC. Gasping state. You can see the patient is coming in the gasping state. His doctor is not running after the antivenom. He called me. I am over phone. But he had given the Ambubac assistance. Okay. Then he have given the neostigmine atropine. Then only he have infused the antivenoms. So he is not panic. You can see patient. He is very much. He have assisted the respiration. He has given the neostigmine atropine, and then only he have infused the 20 vials of antivenom. And you can see who was gasping, who presented in a gasping state, and he will sit. And I request all of you to a big round of applause to this doctor, because he is an MBBS doctor. He is not an anesthetist. He is no specialist at all. So this can be treated. We already explained that there is no need of ICU if the patient comes at the earliest to your hospital. So blunder 10, that is the children. Suppose in the night time they will come, and they cannot say, "Sir, doctor, we have a dysphagia. They will she will not going to tell you." So there may be excessive cry. There will be again hypotonia. Suppose patiently having the excessive cry, suddenly they will stop crying. And the night time, it may be crate bite. You think the patient is sleeping, the child is sleeping. Then what will you do? How will you monitor? Pinch over the chest every 1 hour for first 6 hours. The first 6 hours is important. Jodi sokotoko melise kandise, then okay. This is envenomation not happen. But every hourly you do, and you ask your sister to do that. If the patient is not opening or crying, means envenomation is happening. So do not think that patient is sleeping. So because of this, Government of Assam, we have reduced the date from 150 plus in 2022 to 27, and we are targeting 0 death by 2030 in Assam. So ASB reaction sometimes happen. The adrenaline is the drug of choice, and the dose is 0.0 milligram per kg. ASB contraindication is nil. You do not have an ICU, do not worry. Ambubac is the rural ventilator, and this is the patient who was saved by Ambubac in our hospital with chest compression. No ICU, no worry. We should have tie up with a private ICU. We have tie up with a private ICU because we do not have any ICU. And this lady, pregnant lady, 8-month pregnant lady, we could not infuse the antivenom because of the reaction. We shifted the patient, we monitored the carbon dioxide, but later she delivered a male boy, and we termed it a Mitrunjoy. Okay, without antivenom she survived. So this is the 3-month pregnant lady who was again bite by this crate. Patient required intubation ventilation. We patient shifted with an ambu bag assistance to private hospital, and we keep the patient. And later she delivered a female girl. We termed her Mitrunjoyi, and this is her first birthday we have celebrated. So this patient presented with a brain death, apparent brain death and cardiac arrest. In the crate bite, sometimes the patient present with an this one brain death scenario, like pupils are dilated and etc. So you do not declare brain death immediately in case of snake bite. Again, this is an apparent brain death but recovered, apparent brain death recovered. So this is already we have published in the American Journal. So our model has been taken by this ICMR to study already where the study is going on. To conclude, to 20-minute whole blood clot test 1 hourly for the first 4 hours, followed by 6 hourly. If positive and it is not in green color, yellow color, pit viper is always green color or yellow color. If it is not green or yellow color snake, infuse 20 vial of antivenom. Increasing pain and swelling, vomiting, infuse ASV. Crate photo available, no ICU, but no symptom, infuse 20 vials of antivenom. Do not wait. Maximum vials of antivenom 25 vials. If the patient is not improving, go for the other supportive measures. Neurotoxic symptom, the first drug is the atropine and plus neostigmine. Never forget that. Then only run after the antivenom. Respiratory compromise, the drug is the rural ventilator, and rural ventilator is nothing but your ambu bag. Every community health center is having the ambu bag. You please use that one. So this is my number whenever you require any type of assistance, because I am basically an anesthesiologist, but snakes and the snake bites are my patient. Anytime you need any assistance, I am always happy to help you. Thank you very much. I have finished on time, I think.
Thank you, Dr. Giri, for your detailed description, and you have covered all aspects of snake bite.
Yeah, thank you.
Only to add up 2 or 3 points, for prevention of absorption of this venom, we should keep the lymph down below the level of the heart. That should be advised. Not
madam,
below the level of the heart, the lymph should be kept, because snake bites at the periphery of the limbs. So the lymph should be below the level of the heart.
Not
don't elevate the lymph.
No, not necessary, madam. Not necessary, not required, because venom sometimes goes through the venous circulation, sometimes go through the lymphatics, so you cannot prevent that. So anyway, if the
some
venom
amount
is injected,
of central pulling will be little less.
no,
for
madam.
that.
Even if the patient comes with the pain and swelling, we keep the patient elevated, and his limbs should be elevated.
But now they are telling to him to be
No, this is wrong concept. Actually, the previous concept was there,
Achha.
but what is better? It should be immobile. The only thing the limb should be immobile, and if there is a swelling, we increase this one, elevate the limb like this.
Another advice is most of the farmer gets this bite, so they should wear the hard leather shoes. I mean, covering up to knees when they are going to the
Yes, to prevent the snake.
Number 3 is death is due to the delay of in starting treatment. Due to the concept, till now the village people have the concept of Oja. They first go to the people Oja, and then when it is not cured, then you go to the hospital. So there should be awareness that you should go.
So that is what we are doing, madam.
Yes.
The Nobel model, that is we have already explained, so it has been presented in national and international forum. So we are keeping on. There is the participating of the community. If the community, suppose you have AIMS hospital, you have about ventilator or the 10 numbers of anesthetists, but the patient comes after 4 hours. There is no use. So what we are targeting, patients should be attended at the hospital at the earliest.
Only thing, most of the snake bite is non-poisonous.
Yes, already I have explained
that you have saved.
14% only venomous. Out of this 14%, only 2% require antivenom. So,
Exactly.
and another 12% does not require antivenom at all.
Yes, thank you.
Is tourniquet mandatory in any kind of bite?
So tourniquet is not mandatory, but it is Sri Devi who actually told us, our public, that it should be tight and it should be like sucking, etc. So it has been this is a movie. The movie effect is already in our this community. So to prevent that actually very difficult. But many people already we have reduced to 70%. 70% tourniquet we have reduced in our communities. But you can say 99% people they use the tourniquet. So it is not we are advocating, but the communities are advocating.
Tourniquet is causing no harm because
Yes,
it is
tourniquet is good. We do not advise tourniquet.
Okay, thank you.
Any question from the participant?
Thank you, Dr. Shurajit, for nice presentation. I have one query regarding infusion of anti-snake venom. What we do in our hospital, we give adrenaline subcutaneously IM before infusion of anti-snake venom, first 10 vial, which should be completed in 1 hour, subsequently followed by another 10 vial. And
So which place you are from?
Alipurdwar.
Alipurdwar. So yes, because you have the big four. We do not have any big four. You have big four. That is why the national you are following the national guideline 10 plus 10. That is
Yes.
that. And also it is said that if you give the subcutaneously adrenaline, it will prevent the reaction. But we have
Yes.
tried. But we have not. Suppose if the blood transfusion, are you giving the hydrocortisone, Avil, pre transfusion? No, whenever the reaction develops, then only you give. So in our institute also, we do not give adrenaline subcutaneously. It has no use. We have tried it, but whenever the patient develops reaction, we give the adrenaline.
And another thing, in West Bengal, we follow the right protocol for awareness of the patient.
Exactly.
That is reassure.
True.
Yeah. Another is immobilization.
Immobilization.
Go to hospital and tell the doctor.
Yes.
So immobilization in a patient with snake bite is very important.
True.
And regarding, you see, the application of tourniquet for a general public, it's very, if it is applied by general public, it's very dangerous.
True.
Because it may lead to your gangrene also. And the previous concept, like you're cutting the bite side and squeezing the blood,
These are all
everything is
harmful.
obsolete.
No, tourniquet, what we are not advocating. The patient comes with tourniquets.
Okay.
So we have to change the behavior of the society. So it will take some time. Definitely it will take some time.
Thank you. Thank you. Thank you.
Yeah. You are from which place? No, you are from which place? That is important. Huh? Lambing 20 vials is required. Not for the pit viper. The lambing also the commonest bite is by the pit viper. And pit viper don't need of antivenom. But if it is in crate and cobra, 20 vials. Because in Assam we do not have any big four. Antivenoms are against the big four. So what the national guideline is for the big four. Big four, that is 10 plus 10. So but already I have shown it, that is in the Tezpur University already we have proved it. So 10 vials does not work. So even we also proved it. So 2018, before 2018, we have injected 10 plus 10. Patient died. Patient required tracheal intubation. But when we switch to the 20 vials, the patient has, the mortality has reduced. The ICU admission is reduced. So no concept of 10 vials in Assam, in Northeast. So it is 99% they will come with tourniquet. Yes, you cannot release it if it is in more than 1 hour. More than 1 hour, and you be careful. Even in the anesthesia, whenever you give the blocks or the spinal, they use the tourniquet for there is orthopedic surgeon. So immediately after 1 hour, when we do releases, there will be bradycardia, hypotension, and cardiac arrest also. We have witnessed this. So same thing applies. Any tourniquet, whenever the greater than 1 hour, then you have to be careful. You use the BP cuff and then slowly release. And if you are thinking it is a venomous bite, patient is like I have shown the photo of the lady. If the patient is increasing pain, swelling, vomiting, you first give the antivenom, then you will release with the tourniquet by using the BP cuff. Thank you. Any? Okay.
neostimin alone, without that intake, and neostimin is not available. Giving frequent atropine neostimin alone for a period of 24 to 40 days, if AAC is not available, can it save the patient? Because
Yes, that's same. You will get some time. Suppose you are working in a CSC or a PSC, patient is already neurotoxicity, you give this neostigmine atropine, Ambubec assistant, and patient shift to the nearby hospital where the antivenom is available. That can be done. So we'll purchase the time by giving only the neostigmine and atropine. If it is an cobra, but it's been great, neostigmine and atropine has no role.
This ASV supply is not available in certain places.
No, sir. It is already, NAPSI has already told that every community health center should have the antivenom. In Assam, all community health center is having the antivenom, and already NAPSI guideline already says, National Action Plan says, up to CSC, you should have the antivenom availability.
No, but practically speaking, the supply is not there. Sometimes when
so you have to raise the concern with the nodal officer. Like I have shown you the nodal officer. Whenever suppose X hospital he went to the patient and there is no antivenom, we already informed him, and then in return that antivenom is not available, then he will give the antivenoms.
Would you be advising state-wise a different composition of anti-snake venom?
Exactly. So we are talking about we are also, Assam is going to have our own regional antivenoms, maybe around 5 to 6 years later. And you are in the Chennai because this Tamil Nadu Irula.
Gindi.
Yeah, Irula committee, they will catch the snake. They are the big four, and then extract the venom. From their venom, we are producing the antivenom. So your antivenom works fine in case of Chennai and the Tamil Nadu.
Thank you.
Thank you.
Thank you, Dr. Giri. It was a nice talk. It was a nice talk. And he is available. You can talk later on also. Thank you, Dr. Giri. Next.
Thank you, sir, for your insightful knowledge. Next, Mulana. So, for continuing the session, I like to call upon our next speaker, Dr. Kundan Hazarika, sir. He is currently affiliated with Narayana Multispeciality Hospital at a post of consultant at Critical Care Medicine Department. He has been honored with multiple achievements, like he has been IDCCM teacher, then followed by IMA North Guwahati secretary and ISCCM past secretary. He has been a faculty at various of national conferences. His areas of interest for toxicology in ARDS, sepsis management, management of tropical diseases, trauma and hemodynamic monitoring. We welcome you, sir.
Good morning, everyone. Good morning, respected chair. Today I will be speaking on sepsis and organ dysfunction. This is a big topic. I have just 20 minutes to speak on. I'll be talking about sepsis through the surviving sepsis guideline. We'll take a case that has come up in our ICU. Sepsis and septic patient is one of the most common subset of patient that comes to the ICU and the emergencies. The septic patient have a very high risk of in-hospital mortality. That is why we have to give our emphasis on sepsis and septic patient. Approximately 20% of all global death is caused by sepsis. Whenever a patient comes to you with sepsis and septic shock, mortality is around 30 to 50%, which is very, very high. It is one of the most it is one of the conditions with the highest mortality that is encountered in the emergencies all throughout the world. So why there is an alarming rise in sepsis? Nowadays, because of the advanced ages of the patients that we get, increased number of invasive procedures that is done in the ICUs, wide use of immunosuppressive drugs and chemotherapies, and the dreaded antibiotic resistance. All this contribute to increased number of patients coming to us with sepsis. Why early identification and intervention is important for sepsis patient? Early identification and appropriate management in the initial hours after the development of sepsis improves outcome. That is something we have come to know. Each hour that has elapsed after the presentation of a patient in sepsis, if we delay the administration of antibiotics, every hour delay increases 9% chance of mortality in these patients. As I was preparing this slide, the Surviving Sepsis Guideline 2026 has come up. There are a few changes, not a major changes from the 2021 guideline. Surviving Sepsis Guideline is basically the evidence-based recommendation for the doctors to deal a patient of sepsis and septic shock. So when we say sepsis, what do we actually mean? Sepsis, it is a life-threatening organ dysfunction caused by dysregulated host response to infection. So whenever there is an infection in a patient, the body fights the infection, the body secretes interleukins, tumor necrosis factors, and these infection is taken control of. But in a septic patient, what happens? This immunoresponse of the patient becomes dysregulated and it starts harming the patient itself, or it starts harming the organs. This is what we call as sepsis. The other end of the sepsis, it is septic shock. What do you mean by septic shock? It is a patient of sepsis in hypotension, which is requiring vasopressors to maintain a MAP of more than 65, and even after resuscitation, the serum lactate remains more than 2. So these are the patients that we call as sepsis with septic shock. So we will take a small clinical scenario. It is a 59-year-old male, a known case of diabetes and hypertension, presented with the chief complaint of increased frequency of micturition for 3 days, high-grade fever associated with chills and rigor for 2 days, pain abdomen for 2 days, and pain in the right flank. In the history of present illness, the fever was high-grade, intermittent in nature, associated with chills and rigor. The increased frequency was associated with burning sensation and flank pain. The patient also gave a significant history, past history. The patient underwent TURP surgery 2 months ago and was on Foley's catheter for 4 weeks. He is a known diabetic for 8 years on OH and insulin, hypertensive, and the patient also had a history of hypoglycemia 1 week ago, hence the patient had stopped taking insulin. In the emergency, the patient presented with mild drowsiness. The heart rate was 115, slightly tachycardic. BP was 94/60, hypotensive, knowing that the patient is hypertensive. Respiratory rate was 28, saturation was maintaining in room air. In general examination, otherwise everything was normal. Dehydration was positive and capillary refill time was more than 3 seconds. Patient was febrile, RBS was 350, but serum ketones were negative. There was mild tenderness all over the abdomen. At this moment, before the labs and the imaging, the patient is already telling us something. What is it? The patient, known hypertensive, has fever, flank pain, now is hypotensive, tachycardic, mildly drowsy. What is the patient telling us? Correct. This patient is already in sepsis with septic shock, right? So the provisional diagnosis in this patient, urosepsis with septic shock. We are still waiting for the labs. Hypertensive, diabetic with hyperglycemic state. So sepsis is a medical emergency. Like the stroke protocol, like the STEMI protocol, where time is tissue. Even for sepsis, time is tissue. We have a code sepsis in our hospital. This is the sepsis tool guidelines that we follow. As soon as a patient comes into emergency, or we have picked up a patient in the ICU that we think the patient is in sepsis, this is the sepsis screening tool. See here, this is the history part, and this is the part which is most important. This is the 1 hour sepsis guideline. So what is the 1 hour guideline? As soon as the patient presents to us, your timer starts, and within 1 hour, these are the things that has to be done. First, you take control of the airway breathing and circulation. Then you administer adequate boluses of fluids. We will discuss what fluid, how much fluid. IV vasopressors early use, cultures, 2 set of blood culture, 1 set of urine culture. You measured in lactates and early administration of antibiotics wherever it is required. So the surviving sepsis guideline also tells us that you should assess the patient with clinical tools. So we have the clinical tools, that is the news score and the SOFA. This is all available in the Google. You can go through news. They just tell you that the patient is landing up in sepsis and whether the sepsis is progressing or not. So when we are assessing a patient of sepsis in the ICU or in the ER, we do not have to have fancy gadgets. The number one recommendation by surviving sepsis guideline is capillary refill time. So we all know how to do or how to see the capillary refill time. We press a word in nail bed for 5 seconds, count till 5 seconds, leave it, and we see if the redness has come back or not. If the capillary refill time is more than 2 seconds, that means your patient is dehydrated. And if it is more than 3 seconds, it is an alarming sign that there is the peripheral circulation has been compromised. So you have to act first. So this was a Andromeda shock trial, very famous. It has seen that the personalized hemodynamic resuscitation timing was targeted with the capillary refill time, and it has been seen that if you use capillary refill time for your resuscitation is early and the patient benefit is more, the mortality decreases. If you have a ABG, you will get the lactates. If you have to resuscitate a patient with capillary refill time, seeing the capillary refill time or the lactate, it has been seen that both are equally effective. You do not have to have the lactate. If you do not have the ABG, it's okay. You can see the capillary refill time and resuscitate this patient. Another point of confusion that most of us have is procalcitonin. We always think, let us wait, we will see the procalcitonin. If it is high, we will administer antibiotics. That is not the recommendation. The only recommendation for procalcitonin is to de-escalate antibiotic or for stewardship of antibiotic. So what is a procalcitonin? It is a peptide precursor of the calcitonin. It differentiates generally between bacterial and non-bacterial infections. Generally, the PCT is more for gram-negative infection than gram-positive infection. Surviving sepsis guideline directly recommends not for initiation of antibiotics with procalcitonin, but is recommended for antibiotic stewardship. So once you have seen that you have diagnosed the patient is in sepsis, what is your next response? The patient is hypertensive. What you want to do is you want to give fluids, whether it is in the ICU or in the ER or in the OT. Your next treatment is fluids. So first you have to decide what fluid you want to give, whether it's a colloid or a crystalloid. What is your general preference, the crystalloids or the colloids? Crystalloids. Why is it so? Because by now, since 2014, we have had plenty of studies. The HES trial, the LPOS trial, all those studies have told us that if we use colloids, the chances of AKI is more. Even if you are using albumin, for traumatic brain injury patients, it has been seen that the 24 months mortality is higher with the albumin group. So now we have decided that we will be using crystalloids. Now which crystalloid to use? What do you generally prefer? We have crystalloids like normal saline, we have crystalloids like buffer solution. So given a choice, which one will you use? So see, the normal saline is the basic teaching that we know. Always use normal saline for resuscitation when you do not have buffered crystallite solution. But from studies now we have come to the conclusion, whenever we are using normal saline, what is the harm? 154 milliequivalent of sodium, 154 milliequivalent of chloride. This is supraphysiological levels of chloride. Normal chloride is 98 to 100, right? So when we are pumping this much of chloride, what is the harm? This chloride causes the efferent vessels of the kidney to contract, right? And what it causes is it decreases the GFR, and hence the chances of AKI is more. It causes hyperchloremic acidosis in patients where we are trying to resuscitate with normal saline. So these are the studies that have been done. These are old studies. Now we almost know, or it is almost confirmed, that we should be using buffered solution. So this is another trial that was published. This Fleet trial, it is also a very famous trial. The LBOS, or the basic trial, is the other study. It clearly says that if we are using balanced crystalloid solution, there is decreased mortality, decreased chances of renal replacement therapy, decreased renal dysfunction. This study was done in around 15,000 patients. So it has settled the debate that when we are resuscitating, we should be using balanced crystallized solution if we have the option. So now we have decided we will be using balanced crystallized solution to our patient who was there in the ER. So how much of fluid will you give? We cannot give n amount of fluid, and we have to decide an end point where to stop, right? So now we have decided the balanced crystalline solution. The earlier teaching was give bolus of 30 ml per kg body weight, but you cannot give 30 ml per kg body weight to all the patients. Suppose a patient comes to you who is CKD, having pyelonephritis, who is on dialysis, or who has LVF. Can you give 30 ml per kg body weight? 60 kg body, you will have to give around 2 liters of fluid. The patient will definitely end up in failure, right? So we have to devise a mechanism to see if the fluid that we are giving is actually working in the patient, and we have to give in a way where we give small boluses so that we can see the response. So it is seen that more than 50% of patients in which fluid loading was clinically indicated are non-responders and are being given fluid unnecessarily. So whenever we are thinking of giving fluid to a hypertensive patient, always think in line of fluid resuscitation, and for that you have to define inadequate tissue perfusion. Not just BP. The BP is not your marker. Always try to justify inadequate tissue perfusion. And how will you do that? You have to have hypotension, oliguria, elevated lactate, prolonged capillary time, malted skin, and altered mental sensorium. If you have this point, then you can go for fluid resuscitation. And how will you resuscitate? You will give small fluid challenges. The easiest approach to evaluate fluid responsiveness is to perform a fluid challenge, right? It is a dynamic test of the cardiovascular system that assesses the preload reserve of the patient. The fluid volume given must be sufficient to stretch the right ventricle, increasing diastolic volume. That is the Frank-Starling law. What it means that whenever you are giving a fluid to a patient, try to stretch the myocardium like a catapult, and the myocardium will contract vigorously, pushing the cardiac output. That is our goal. That is the Frank-Starling law. Usually we give 20 to 50 ml of crystalloid, that is 3 to 4 ml of crystalloid per kg body weight, and the most important part is the rate of administration. What we do generally, the patient is coming in shock, 500 ml fluid लगा दिया, 1 घंटे तक चलना है, ऐसा नहीं है. The rate of administration is more important. The rate of administration is of critical importance. Fluid should be infused over a period of 5 to 10 minutes. 250 ml bolus, crystalloid, 5 to 10 minutes. Again, see the response. If you have response, give another bolus, wait, give another bolus, wait. Not you give 2 liters over 2 hours and wait for the response. That is not the way to give fluids. So whenever we are giving fluids, what are we looking for? We are not looking for increase in BP. We are looking for increase in cardiac output. But generally, how do we look for cardiac output? We see the mentation. If the patient is ICU, we put an arterial line. We see for the stroke volume. We see for the pulse pressure variation. We'll come to that. The response is considered positive when the stroke volume or the cardiac output is more than 10 to 15%. The easiest way to do is to give a fluid challenge, especially in patients who have poor cardiac reserve, is to do a PLR. Especially if you have DNB students, I think this will be asked in your exam, how to do a PLR test. So what is a PLR? It is a passive leg raising test. The patient is lying in 45 degree, legs are straight, you make the head straight and raise the legs. What it will do? It will give a auto infusion to the patient. Around 250 to 500 ml of blood will come from the lower limbs and abdomen to the heart, and it will increase the cardiac output. If the patient improves with this, you will know that the patient is fluid responsive. So this is generally how we manage. If patient requires fluid, we have given fluid, patient responding, we keep on giving fluid, patient doesn't respond, we take out the echo and we see. What we see for the tamponade, RV dilatation, which is very common in septic patient, and we look at the contractility of the ventricles. The other way, this is a huge topic for hemodynamic monitoring, I will just mention. Suppose the patient is still sick, you are giving fluids, and you have to monitor whether the patient is improving or not. There are two ways how we do it. We use static and dynamic parameters of hemodynamic monitoring, right? Static parameters we all know, we see for the IVC with the ultrasound, we see the dilatation, we see the movement of the ultrasound. If it is IVC, if it is more than 1.5, the patient might not be responsive to fluid anymore. For the invasive part that we generally use in the ICU is the stroke volume variation and pulse pressure variation. The only caveat for this is that the patient will require an arterial line and preferably be on ventilator, because we do not want respiratory variations in these patients. So pulse pressure variation for exam going, if there is anyone, pulse pressure variation more than 13, patient is fluid responsive. Similarly, stroke volume variation more than 10%, patient is fluid responsive. So you have decided on the fluid, you have given fluid, even then the patient is not responding. Now what? We have assessed the patient was hypotensive, we have decided on crystalloid solution, we have given buffer solution, we have given fluid boluses, but still the patient is hypotensive. So in a septic patient, what will be your next line of treatment? This is also important for the anesthetist here. Never be scared of starting the vasopressors. Especially if you are thinking that the patient is in sepsis, early use of vasopressors improves mortality. It is recommended that for starting noradrenaline or any vasopressors, you do not require a central line. Use the peripheral lines. This is the sensor trial that came up. It shows that early use of non-adrenaline improves shock within 6 hours. The vasoactive amine for choice, number one is the norepinephrine, dose you will always get. Second line of choice is the vasopressin, and third is epinephrine. This is the surviving sepsis guidelines. So you have given vasopressors, now you have the, within 1 hour you have to decide antibiotics. You think the patient is in urosepsis, patient is in shock, you have given fluid, you have started vasopressors, now antibiotics. How will you decide the antibiotic? This is one of the most commonest confusion, which antibiotic to give. Right? So, see, we have an antibiogram. Our hospital, we make an antibiogram every 6 months. Suppose we take the patients like community acquired pneumonia patients coming to us, we do the culture, this is the organism and these are the antibiotics that the patient genuinely respond. And accordingly, we have an empiric antibiotic. So whenever we see that a patient with community acquired pneumonia coming to us, we start with the antibiotic that is given in the antibiogram. Later when the cultures come and it shows that the patient is suppose MDR, then we can always change the antibiotic. So this is the antibiogram for urinary urosepsis patient in our hospital. This is just an example. So you have to give the right dose, right size. I'll take another 5-10 minutes. Yeah, right size, right dose, and local antibiogram. Your right dose is very important. Why? Because sometimes the patient coming to you with sepsis, they are already in AKI. So in those patients, do not decrease the dose of antibiotics seeing the creatinine. In those patients, the volume of distribution is very high, so you give the adequate dose. So in this patient, we had started piperacillin tazobactam. We send the blood parameters, culture, ultrasound was advised. Other diagnostic tests, these are the new tests. The patient was diabetic, so insulin was started, and surviving sepsis guidelines says that you should be maintaining the sugar between 140 to 180. Very tight sugar control leads to hypoglycemia. Proton pump inhibitors, again recommended by the surviving sepsis guideline. Another important part for any septic patient is your DVT prophylaxis. Always start with low molecular weight heparin, or if that is contraindicated, then you can start unfractionated heparin or mechanical thromboprophylaxis. So in day 1 in ICU, the patient's TLC was still high, 22,000, creatinine high, other electrolytes were okay, urine showed plenty of pus and nitrates, and LSE was positive. Day 2, patient still drowsy, still sick, moderate noradrenaline requirement was there, the patient condition remained critical. Now what? So since we know that the patient was in sepsis, we had started all the medications, so we have given the septic dose of hydrocortisone. This is also recommended by the surviving sepsis guideline. Give 200 mg of hydrocortisone stat followed by 50 mg QID. By that time the ultrasound came. Ultrasound showed echogenicity, dirty shadows around the renal pelvis, and was diagnosed as emphysematous pyelonephritis. By this time also the culture came. The organism was Klebsiella but was pen sensitive. At this point in time, what else would you like to do? The patient is still in shock, not responding. You have given antibiotics. Your Klebsiella is the organism, pen sensitive. Will you add any other antibiotic in this case? Pardon? 22,000, persistently high. So here comes the most important part, your source control, right? See, the studies have consistently showed that your source control decreases mortality in the patients. So what we have done, we took a urology consultation, plan for DJ stenting, and procedure was done. In the very next day, the TLC came down to 14,000. But there is one catch. This was day 4. In the chest, on auscultation, we started getting some basal crepes. And we decided to give some diuretics. Why is it important? See, whenever we are giving fluid, the fluid is a drug, right? Fluid is a drug. When during resuscitation we give fluid, it is for the resuscitation of the patient. We have a concept called ROSE concept: resuscitation, optimization, stabilization, and evacuation. The fluid that is a medication during the resuscitation becomes toxic in the optimization and stabilization stage. So that is the time we should be trying to de-resuscitate this patient. It is seen that 10% accumulation of the total cumulative fluid by day 3, if it is more than 10%, there is worse outcome in the patients. We have gone into the septic patient to resuscitate, but if we leave that fluid inside, that there will be third spacing. The ICP increases, the perfusion in the brain decreases, your renal blood flow decreases, AKI increases, there is abdominal symptoms. So we have to make a plan that this is the time we stop, and that by this time we try to de-resuscitate. So it is seen that by day 3 of any septic patient or septic shock patient that you have resuscitated, by day 3 try to maintain euvolemia or equal balance in this patient. And by day 7 try to maintain some amount of negative balance. By some amount, it means that somewhere around 500 ml of negative balance. For this, what we do, we give diuretics, or in some patients we have to go for renal replacement therapy. By day 5, antibiotics were continued. Patient was shifted to ward. Patient was further managed 2 days in ward. Urology reference was done, and by day 7, the patient was discharged.
Time is over.
Yeah. In conclusion, sepsis and septic shock is devastating. Use SOFA, Q SOFA, Muse and News. Time is tissue. Early patient-specific resuscitation is very important. Whenever you are resuscitating, remember the Frank-Starling law. Monitor the macro and macrovascular compartments. De-resuscitate the patient using the ROSE concept. Thank you.
Thank you, Dr. Hajarika. Only 1 or 2 questions to you. One thing is, for response of treatment, we have to do serial lactate level. Lactate level serially to be done, number 1. And you have mentioned already Q SOFA.
Lactate. The surviving sepsis guideline clearly says that you don't have to keep on doing the lactates. If you have lactates, it's fine. Otherwise, your CRT is as good as lactate.
Well, number 2 is, did you think about antifungal? Because if patient doesn't respond to the antibiotic proper, then are you thinking of using antifungal? Yeah. Because fungal culture is not available everywhere. Empirically, do we start antifungal?
No, until and unless the patient is immunocompromised. If we are dealing with some kind of an abdominal sepsis, we do not start antifungals, ma'am. And there is no recommendation as such. In this case, we have the clear idea that there is some kind of a urosepsis, and by day 2, day 3, we had the culture.
What are the major differences between the 2021 sepsis guidelines and the 2006?
2021 guideline and the 26
Just maybe 4 or 5 differences
the
that we...
main is that they are recommending antibiotics to patients who if we are thinking that the patient is in sepsis, they are recommending giving antibiotic before the patient reaches the hospital. Number 1. Number 2, they are
taking the blood culture also.
Yes, before taking the blood culture. They are emphasizing the antibiotics as such that you have to give it if you think. Second, they are thinking in lines of that. Previously, they said that maintain a MAP of somewhere around 65, but it has been seen that it is very difficult. So they want the MAP to be above 65, above 60 to 65 in between, but not more than 65. That is the main recommendation. It is mostly of antibiotics.
Now, any questions from?
It is very difficult. If you send an interleukin, if you take a sample, if you don't have a state-of-art lab, you won't be getting the correct results. Yeah.
Any question from the audience?
No, sir. Sir, in primary healthcare centers or in remote areas where we do not have a pediatric available, this capillary reperfusion time, can it be useful for pediatric population to assess dehydration and shock?
Absolutely. The pediatrician, they almost do the capillary refill time very frequently, and it has been recommended that you should use it.
And if we suspect at that time there is a dehydration or shock, what is the immediate fluid of choice and before we shift to a tertiary care?
Balanced crystalline solution, or sometimes isolite P.
What is the possibility of starting on cholesterol if the renal parameters are equivocal or
It depends where the multi-drug resistant organism is affecting. Suppose it's the kidneys, then you can start maybe cholesterol. The dose, your initial dose has to be 9 million units. Then you can decrease it according to your creatinine clearance. We generally do give, suppose 9 million, then 2 mu BD, 2 mu TDS, depends upon the creatinine clearance.
Thank you, Dr. Kundan. It was a nice talk. And one comment that you have your own antibiograph. That's very important. And I think that each and every hospital should have their own.
In Guwahati, we are collaborating with all the hospitals, and we are asking every hospital to get an antibiogram, and that with that antibiogram we will have a collaborated Guwahati antibiogram so that we can use it for reference.
Yeah. Thank you. Thank you.
Thank you.
Thank you, sir, for your thoughtful session, and also sharing with us your own personal experience in managing patients of sepsis. Next, I would like to call upon stage our next speaker, Dr. Gaurav Singh. Sir is a medical affairs professional with deep expertise in infusion therapy, patient safety, and infection prevention practices across diverse healthcare environments. Sir is a JCI certified prime trainer with specialized proficiency in reducing infections, invasive line complications, and medication-related errors within IV therapy workflows. Sir has a strong clinical foundation with past association at Tata Main Hospital, Jamshedpur and Adanipur, contributing across a broad clinical portfolio with a focus on infection prevention, invasive line safety, and patient safety frameworks. I request Sir to come upon the stage and proceed. Thank you, sir.
Hi, good morning everyone. I'm Dr. Gaurav. I'm here with BD. So I have a 7 year of clinical experience. I'm working with BD for past 5 years. BD is a 130-year-old medtech organization which is working on the patient safety, on healthcare worker safety. And in today's my session, I will be taking on to the part and parcel of the CRBSI, a very prevalent infection which is very much predominant onto our ICUs and our critical care areas. Okay. So very predominant infection and pertaining wound which is prevailing in our ICUs and the critical care areas. I will take you on to the Indian data and to for certain intervention which has been done in the Indian setups and which has given a good clinical outcome to the patient and the patient impact. So starting with the prevalence of the CRBSI in Indian data, if I go on to the fact that healthcare and the nosocomial infection are the one which are very pertaining to our settings, and one of the most predominant one is the CRBSI related to the infusion and for the patient manufacturing as well. And if I go with the WHO reports of 2023, the India has a HAI rate of up to 20 times more than the high economy countries, and this is because of the infra and the patient which are caring, the out-pocket caring which we are giving, and the point of care which is having at the patient bedside. Indian ICUs have the collapse rate of 2.5 to 12,000 catheter days, and if it have to compare with the US, so it's almost less than 1 per 1,000 catheter days. So this is one data which is intuiting us to introspect that what is that things that this is leading to this kind of almost 8x time the statistical data showing that this is the what is aggravating onto that infection rate, and it is impacting our patient at the patient bedside. So for starting as a context setting, collapse and CRBSI are two things. CRBSI infection diagnostic parameters are very predominantly briefed on, like on the CDC and JACI, they are given as a certain set of diagnostic parameters onto it. And for the collapse, it is generally a tool which is used for the reporting and the surveillance. So these are two terminologies, I would say, which are not interchangeable. They are one set of patient could have a diagnostic criteria which is filling onto the collapse part, but could not define the CRBSI. So if I sum it up, the CRBSI and collapse, CRBSI pertains to the patient management. When we have to go on to the treatment part of the patient, we are following the diagnostic parameters of the CRBSI, and collapse generally talks about the reporting and the surveillance part. So if you see here as well, in collapse reporting there is no requirement of the culture tip at the page of the catheter, and for the CRBSI, if I go, the any of the two of these diagnostic parameters should prevail to establish diagnosis that this is a CRBSI infection, and one of the most is the differential time positivity. Same organism found taken from the catheter or the peripheral blood side having a positive, the culture coming of the from the catheter 2 hours or more than 2 hours is something which is coming down to the differential time of positivity, followed by the quantitative culture, same organism from the both sides, more than 3/4 of the higher CFU of the catheter blood, and if the catheter tip is available. So I'm not saying that every time we require the catheter tip to be removed to establish a diagnosis of CRBSI. If the infection is prevailing and the WBC shift on that front, we have to be vigilant of it, and these are the two interchangeable terms which generally confuses us. So the treatment part pertains to the CRBSI, and for the reporting and the infection part, we use the definition of the collapse one. To differentiate it up, the collapse and the CRBSI, and what is differentiating and to giving us a sense is that the tip culture and the differential time positivity to establish a differentiate of the collapse versus CRBSI. And to establish onto the pathogen part, one of the most important thing is the intraluminal and the extraluminal pathway. As Dr. Hajarika was also mentioning, that the source of infection is one thing which has to be contributing onto the factors that what is leading to this kind of the infection. So intraluminal is something which is generally hematogenous spread, blood-borne, whenever there is a debris of our residual drugs into the RV catheters. On the extraluminal sites are generally the migration of the skin microorganism, and the majority of those are the Coagulase negative Staphylococcus species, which are the general still commensable microorganism which are available at the skin site. Through the site of infection, they are going to that our bloodstream and leading to these kind of the infections. To differentiate onto the two fronts of it, which are the intrinsic factor and the extrinsic factor. The intrinsic factor is generally the non-modifiable one, the patient age, the underlying disease and the comorbidity which we can't modify. But the few things which you can work on to establish this infection and to carve onto the prevention of this part, starting with the prolonged hospitalization, practice part of that particular aseptic handling of that particular device. Site of selection comes into a major role, which is for the femoral and through the interjugular site of access, which we are going for the insertion of these devices, followed by the multiple lumen of the central venous catheters. Our open port is a source of infection, and any source of infection could lead to this kind of lethal complication in the infection at the patient's bedside. And how these are impacting onto the patient front is not leading to the morbidity, followed by the mortality, extent length of stay, and imparting of the cost of treatment to the patient, which is taking care of the patient cost, and obviously the increased length of stay is leading to the excessive use of antibiotics to curb on to curtail all those infection part. What Dr. Hazarika was also mentioning, that antibiotic biogram is something which we are going on to that front. Empirical treatment is followed by these kind of treatment protocols as well. So when I say that the excess length of stay is there, so if you go with the statics data, almost 2x is the length of stay which is going to be pervading because of these infections, and which lead to the mortality in Indian setup is almost 3x. Established CLABSI patient could lead to a mortality of 3x versus to the patient which has been in the Western world. And if I go into the contributing factors of it in the subsequent slides. So when I'm saying that a patient which has been established with a CRBSI or a CLABSI is having excess length of stay. What it means, whenever a patient is there, excess length of stay is not only impacting that particular patient. In Indian setup, we have a limited set of critical care, limited set of ICU bed. A patient extended length of stay because of these infections which are preventable, not only holds a bed for that particular patient, but also for a patient which is eyeing for that particular bed. So just for a saying for a term, that a patient who was in the evening was established that this patient will be shifted to an ward for management, a spike of fever, a shift of WBC. We are holding that patient onto the critical care site. We are holding an ICU bed, and that is not only impacting that particular patient, also the patient who are in the line to get those ICU's bed. Hence, prevention and identifying that contributing factors of this infection plays a very pivotal role in prevention of these complications. To establish the statistics that how many CLABSI rates have been reported, how many CLABSI rates are reported, I will show you data. So this is a Indian data which has been done in the southern eastern part of the countries, including India, and one of the major contributing nosocomial infection comes into the picture was CRBSI. When I say CRBSI, it is an intravenous device related one. So it includes the central line and the peripheral line both. And how these are impacting at the patient side is that a patient which is having a CLABSI rate has a extended length of stay, has increased cost treatment, and in statistic wise, the adult ICUs having a 5.3 CLABSI rate per 1,000 catheter days versus US, which is having 0.8 per 1,000 catheter days. In my subsequent slide, I will talk about what are the contributing factors which have led to this kind of a drastic shift of the data, because they are also treating a patient in the critical care. We are also doing that. What is that shift which is leading to this drastic change of infection rate at the patient bedside? So CLABSI is one thing which is not predominantly being monitored in Indian ICUs, but this is also a very pivotal one which is leading to the complication at the patient bedside. These infections which are leading to the increased length of stay of the patient, Adiabatic use of the antibiotics, which is right now we are going for the antimicrograms, imperial therapy, use of the antibiotics, and these are the things which are leading to the multi-drug resistance and the pan-drug resistance at the patient bedside. So epilepsy is also almost 51% of the patients who are having epilepsy get onto increased length of stay, which is almost 2 times versus the patient who doesn't having a epilepsy, and it was done in the adult and the pediatric ICUs, where there are more chances of getting a breach of the aseptic monitoring of the particular patients. And these are the contributing factors I'm talking about. So establishing this infection requires certain diagnostic tools, but if I go onto the prevention part and we deep dive onto it, the contributing factors are more or less onto the part of the how we are handling our patient at the patient bedside, how we are maintaining the aseptic protocols of the handling of our IV catheters or the devices which has been pertaining at the intravenous or the invasive procedure which has been done at the patient bedside, be it a FORE catheter, be it a IV catheter. So these are the things which are going on to the factors of leading these kind of infections, starting with the crowded ICUs, open ports, these kind of the three-way stopcocks we generally get at the patient bedside for extension of the length or getting a multiple valves for the medication management, opening port at the patient bedside, having a needle spike at the peak of the bottle, handling a central line catheter without following the standard precaution, bare minimum the gloves are being used, and followed by the open burette as the patient, pediatric patients as well, which is leading to a open port source. So what I'm trying to disseminate here through you guys is that awareness at the patient bedside, and for through you the clinician, is that every open port could be a source of infection to a patient. Every aseptic breach could lead to the complication, which is subsequently leads to multi-organ failure, which Dr. Hajarika was mentioning during his sepsis demonstration. And then with that terms comes around the antimicrobial use and empirical therapy, and these are the things, these empirical therapy use of the antibiotics are leading to that multi-drug resistance and a pan-drug resistance at the patient bedside. So how we can curb onto it? So there are certain data which has not been intervened at the Western world. Few of these has been already been done in the Indian part of the parcel, and they have get a good clinical outcome out of it at the patient bedside and pertaining to these infections. So sum up a bit is that there is a term called which is called as the care bundle. So the care bundle approach is one thing which starts from right from the initiation of any invasive procedure. Here I am talking about the intravenous catheter. So starting from the insertion parts, site selection part. So at times we feel like these are the very minuscule things which are being done at the patient bedside, but these are the very powerful tools if used as a care bundle, and these impart onto the patient health and very much or predominantly help onto the curbing of these infections, followed by the longevity of that particular device, leading to the less complication and enhancing the quality associated life years of that particular patient which has been come onto that. And the major, I would say that the major hindrance and the obstacle which we had currently is that the workload we are having. We are having a very limited ICUs bed at the patient at the infra perspective. I will predominantly put into the picture. Government beds are very minimal. There is already being the patient laying at the walls and onto the stretcher. So these are few things which is giving us the push at the proper aseptic maintenance of these particular infection prevention control measures. Lack of equipment is one thing, and the training part. So what we have done, we have beautifully put into a care bundle approach, which is called as the care bundle prevention strategies. So it starts with the education of that healthcare personnel, followed by the very basic of it, which is the hand hygiene, followed by the aseptic techniques, which starts from the preparation of the site. So when we start with the preparation of the site with the maximum sterile barrier precautions, skin preparation, catheter site selection, use of the catheter kits at the patient bedside, and when we are going for the insertion bundles, obviously we are not having a focus at every place, but if there is a possibility of using of the ultrasound guided, we should be going for that, because when we have ultrasound guided, we have the possibility of placing a subclavian insertion of the central line rather than going with the intrajugular one, followed by the dressing regimes, and for the maintenance bundle of it, which is the locking part of that particular device. Flushing of that particular device plays a very pivotal role in curbing these kind of infections, washing out these kind of debris. These of the techniques lead to the less aggression of the microorganism at the site of insertion and in the intranumular of the catheter, which sometimes leads to the colloidal formation and which leads to these kind of the infections. So what we have done is that we are wherever we have gone, we have collaborated with certain tertiary care centers like VHU and the PGI, where they have found that if they go with two interventions only. First is closing all the open ports at the patient devices, like whenever we are going for the central line or the peripheral line, closing of each and every port limits the cross-touch contamination and the aseptic breach. Secondly is the flushing technique and the dressing technique. When we are maintaining our device in a very aseptic manner, that leads to less cross contamination, less touch contamination, and there is less formation of any kind of a residual, for example blood or any drug which is into the intranumular catheter site, which with due respect of time leads to this kind of complication or any kind of a microbial ingression. So flushing is one thing which is one of a very pertaining issue. Sometimes it is being very much overlooked on. So it is a very basic practice to be incorporating it. If you will start doing it, it increases the longevity of the IV devices. It has shown the statistics data that decreases the limiting of the uses of the IV catheters at the patient bedside. We could not get a multiple failure of the IV catheters, and it increases the patient quality care at the patient bedside. So one of the few things is that the using of the ideal solution for a flushing, which is the 0.9% NaCl, which is the isotonic solution. Hence we are the guidelines say that we should be going with this kind of thing, because at times we have seen that people are using dextrose or using any kind of antimicrobial locking as well. So this is which comes as a part and parcel of it. So this is the Indian data. When we have gone into the clubbing of this education intervention, closing every open port to a closed port, following the flushing as a protocol, we have seen that there is a 39% reduction in the CLAPSI rate at the Indian ICUs. So this was a study done in the 8 cities, which was published at the American Journal of Infections. And followed by this, I'm also saying that the adoption of technology plays a very pivotal role in prevention of these kind of infection. Stopcock were used very absolutely in the previous era. Right now the world has shifted to the closed port, which is called the needleless connector for usage at the patient bedside, followed by the practices of having the flushing of each and every device post every medication, so that there's less chances of any kind of occlusion, because all the clinicians will agree with me that most of the time when we are getting any kind of a VAD failure, it is because of because of the occlusion or because of the redness and pain at the site of the selection. So this is something which is giving to a clinical new outcome at the patient bedside. So these are the few things which has gone on to the needleless connector, uses of the closed ports followed by the pre-filled syringes, which has given a good clinical outcome close. So we'll close it or not to work. So when we have shifted from open port to the closed port, this is the microbial profiling of those particular things. So in this data as well, we have seen that when we have shifted from open port to the closed port, when we are onto the open port, Klebsiella was the major predominant microorganism which was getting ingress, and shifting from open to closed port have given Enterococci as the predominant one. So this is also giving a good clinical outcome, that when we are shifting to the open port to the closed port, maintaining of the aseptic techniques have decreased these kind of infection and led to the major patient elevation at the patient bedside, including the reduced IV-related complication followed by the patient outcomes and the improved staff efficiency. And when we are giving it into a conclusion, so these are the key takeaways which we followed. Behavioral is the one thing which we should be trying to disseminate from top to the bottom, giving them a sense that whatever practice they are following is going to impact the patient bedside, either it's a hand hygiene, following the dressing regime, or closing a port with a closed port and following the flushing as a regard. And this we have, these are the INS and the CDC guidelines which we have given as a checklist for the insertion and the maintenance bundle, starting from the site selection and the flushing, followed by the disinfection and the changing of the dressing. And this is for the PIVC as a checklist which we are following and prevailing as the awareness and the patient at the bedside. So thank you so much for your time. Thank you.
Thank you, doctor. As there is a short of time, we can ask many questions.
Sure.
Only one thing is to prevent infection central line. You can puncture the, during puncture, the skin puncture and the venous puncture should be in the separate place. So that tunneling of the catheter should be done to prevent infection, number one. And number two is, there are antibiotic coated central venous catheter. Though we don't know whether it is really helping or not, but to some extent it can help for up to 1, 2 or 3 months you can keep long with antibiotic.
To answer your question, ma'am, that antibiotic pregnated catheters, the clinical data shows that if it's majorly onto the handling part, ma'am. So there has been the clinical data that have shown that if a central line versus the impregnated central line has been followed by the same aseptic manner, both have the same kind of longevity. So it's more about the handling of those devices, because the cross contamination is coming from the either from the site or from the hub. So, and for you, ma'am, the antibiotic impregnated catheters, because as Dr. Hazarika was mentioning, antibiotic microgram is coming into picture. We have gone to the empirical treatment. Azithromycin has been used as the OTC drug. So we are not having these kind of, discovery at the antibiotic place. So we have to curb it out. So antibiotic pregnated though have shown, but clinically it is not. It's more about handling, how we are maintaining our devices at the patient bedside.
Hand hygiene. Hand hygiene is the most important thing.
The hand hygiene is the source of infections. If we are handling our devices, if we are closing each and every port, there is no cross contamination. That depends on the longevity of the device.
Okay, thank you so much.
Thank you, sir, for your informative talk. And with this talk of Dr. Gaurav Singh, sir, we come to the end of our second session. And with due permission from our respected chairpersons, I would like to close this session. I now request our chairpersons, Dr. Shravani Basu ma'am, Dr. Chumki Datta ma'am, and Dr. B.P. Teka sir, to kindly proceed to the felicitation podium for the felicitation ceremony. And I also request our speakers, Dr. Gaurav Singh sir and Dr. Kundan Hazarika sir, please proceed to the felicitation podium for the felicitation. And I request our chairpersons to please felicitate our speakers. And I request Dr. Madhavi ma'am to please felicitate our respected chairpersons. So now we are ready to start with our third session of the day. So to start with the third session, I would like to call upon stage our respected chairpersons, Dr. Abhinav Gogoi sir, ACMS anesthesiologist, Tinsukia Railway Hospital. I invite you to come upon stage, sir. I would also like to call upon stage Dr. Jasper Mar ma'am, ACHT OPD Central Hospital, NFR. I request you to come upon the stage, ma'am. And I also request Dr. Joydeep Sonwal sir, anesthesiologist, Senior DMO, Dibrugarh, I also request you to come up on the stage, sir. With due permission of our respected chairpersons, I would like to start our third session. So I would like to call upon stage our next speaker, Dr. Bhavan Chandra Boro, sir. Sir is a CMT of the City Heart Hospital. Sir has been honored with the Betikram Health Conclave 4.0 for his excellence in the Interventional Pain Management Award 2025 for exceptional work and innovation in pain management. And Sir has been honored for excellence in interventional pain treatment. I call upon Sir to please take up on the stage and proceed.
Good morning, everyone. Respected chairpersons and audience. So my topic is radiofrequency ablations in chronic pain. So as you all know, chronic pain is a huge burden to our society. So it has a socio-economic impact, especially if it affects the productive age group. So you can understand it affects the GDP of our country. So chronic pain is actually neglected and it is neglected topic actually. Many people don't have that awareness. The chronic pain can be managed with many advanced cutting edge technology and all. So many people are still goes on suffering. So radiofrequency ablation is one of those minimally invasive pain and spine intervention we regularly use as a pain physician. So radiofrequency ablation is a non-surgical, it's a minimally invasive procedure. It is the most precise treatment for management of chronic pain. The procedure results in temporary destruction of nerves that are responsible for pain symptoms. So actually it is a utilization of a wave of an electron at a radio frequency to incise, excise, ablate or coagulate any tissue. So a high frequency current is applied to a neural tissue through a closed circuit, and the current produced by the generator runs in active electrode that is called a needle, and it disperses out the dispersive electrode. So a little bit history. So in 1863, Bunis created a direct current in animal brain. Radiofrequency ablation was first used in a patient of trigeminal neuralgia in 1931, and the gentleman Kosman built the first conventional radiofrequency generator way back in 1950. And in 1980s, Slutzer refined Parkinson's technique, and again in 1998, Slutzer first reported the clinical effect of pulse radiofrequency ablations. So to understand the radiofrequency ablation, you have to understand a little bit of electricity. So there is a direct current and in alternating current we will know. So direct current means the current flows from one direction to other, this is unidirectional, and alternating current means the current is changing in every seconds. Okay. So now there are some units which you use in radiofrequency ablation. This is a hertz. Hertz means frequency of alternating current. There is the number of time it changes its direction. It is denoted by hertz. Next, volts. Volts means a unit of electric potential difference from one point to another point. Next is ampere. Ampere is the unit of electric current or the number of electrons flowing through a circuit per every second. And W or watt is the power of electricity, that is volts into ampere. Now in our household electricity, the frequency is 50 hertz. That means we all use this household electricity, this alternating current, we use it, it is 50 hertz. That means it changes its direction in every second, 50 times it is changing its direction. Okay. Now what the RF machine, what we use, radio frequency machine, what it does, it converts this 50 hertz alternating current to 300,000 hertz alternating current. And this procedure is called radio frequency ablation, because this frequency band is similar to that radio wave transmission. Now, how we do these radio frequency ablations? So now it involves a passage of high frequency current through a 27 gauge thermocouple, or it's a probe. This probe is passed through a cannula or a radio frequency needle. Usually it is 20 or 22 gauge cannula, which is insulated except its tip. Now, when this high frequency current is passed, the charged ions around the tissue that moves to and fro, and it causes some electromechanical friction and heat is generated. So that is the very basic principle of radio frequency ablation. Now the tip of this probe is not heated itself. So because of this movement of these charged ions, so positive and negatively charged ions move in the opposite direction, and the neutral ions remains at the same place. So now what is the rule of this tip of this thermocouple probe? Now the rule of this thermocouple probe is, suppose I am setting a temperature of 80 degree or say 85 degree in the RF machine. So when the target temperature is achieved, the tip will give a feedback to the machine that my target temperature is achieved. Thereby, the machine will decrease the wattage, the power of the this electric current, and thereby decreasing the temperature. That means it doesn't allow to go on the current go beyond this set temperature. Thus the heat is totally controlled by the operator. Now this lesion produced by this conventional radio frequency ablation is only 2 to 4 millimeter in size. That is why you have to be very, very precise while placing the needle near any target tissue, or what we call it pain generator. So you have to be precise, you have to place this needle within 4 millimeter of this target nerve. So beyond this distance, the electrical field is weaker and there is no lesion is produced. And now the temperature of the heat lesion is maximum around the shaft of the needle, probe, and a minimum at the tip. On the other hand, the electrical field generated is maximum at the tip and minimum around the shaft. Now this is the sketch of a circuitry and the electrical field of the thermal radio frequency neurotomy. So here you can see this is a ground plate, this is RF generator, pointer, no. Here we can do it. So this is ground plate. This is the RF generator, and this is the electrode in the tip of the electrode. So now you can see the electrical field from the ground plate is concentrated onto the exposed tip of this electrode. Now, what are different types of radio frequency ablations? We have basically 3 types of radio frequency ablations. One is what we call it conventional radio frequency ablation, Next one is pulse radiofrequency ablation, and third one is modified cooled RF. So conventional means there is a continuous wave of radiofrequency is going on, so therefore a continuous wave of radiofrequency current is there, and tissue is grossly heated by the electrical dissipation. Because of this friction of these ions, the heat is produced. And as I have already mentioned, the function of the tip is to sense the target temperature, and while we are receiving the target temperature, it will send a feedback to the machine, and machine will decrease the wattage and thereby decreasing the temperature, not allowing the temperature going beyond this target temperature. The tissue healing, there is localized destruction of neural tissue and the consequent destruction of neural signaling, and this has historically been called radiofrequency thermal ablation or thermal radiofrequency ablation. Now, what are the effects of heat on neural tissue? So, it is reversible up to 45 degree Celsius. That is why in pulse RF we set the temperature of 42 degree. So, because up to 45 degree this neural tissue damage is reversible, and coagulation of protein occurs at a temperature more than 60 degree, and at 90 degrees Celsius the tissue will boil, causing adherence to the probe and tearing to the tissue. Now next one is pulse radiofrequency ablation. So what is pulse radiofrequency ablation? It is also known as interrupted output generator output. The temperature is held at the 42 degrees Celsius. Now here what we do, we give high frequency current at a pulse or in packets and in silence in between. So giving the silence, we are not allowing the temperature to go beyond 42 degrees Celsius. So radiofrequency is delivered in a short high intensity burst, and 2 cycle of 20 milliseconds of each active cycle is given at the high voltage to the neural tissue, followed by a silence of period of 480 milliseconds. Now heat is generated during the active burst and eliminated during the silent period, and here neural injury is very minimal. It is very safe. That is why. Now the mechanism of pulse radiofrequency ablation is not exactly known. There are many theories how it works. So it is said that it's more selective for C fiber denervation. There is long-term depression in the spinal cord, alteration of C4 gene expression in lamina 1 and lamina 2 of dorsal horn, and the formation of messenger, second messenger RNA messenger, and pre-pro-dynorphin and endorphin to modulate the analgesic actions. Basically, while doing pulse radiofrequency ablation, there are some anti-inflammatory mediators are released. So that is the probable mechanism. So there are actually controversies regarding the using of pulse RF, because failure rate is also quite high in case of pulse RF. So there is a difference between conventional and pulse RF. So in conventional RF we are producing heat listen. We can go up to 85 degrees Celsius, but in pulse RF the electrical field is producing the listen. In pulse RF we are not raising the temperature beyond 42 degrees, and electrical field produces some pulse in the capacitor of the small diameter nociceptive fibers, and thereby signal transmission is stopped. There is another radiofrequency ablations which is gaining a very popularity recently. It's known as cooled RF. So what we do in cool RF, it is a new type of RF technology. So water is used to cool the electrode. Now the tissue lies immediate to the cool electrode is maintained at a 60 degree Celsius, and the target tissue is heated up to 75 degrees Celsius for 150 seconds, which leads to a lesion diameter around 10 to 12 millimeter. So while we are doing conventional RF, what we are doing, we are reducing the wattage so that our temperature, the power, we are reducing the power of our alternating current. So here, what we are doing in cool RF, we are not reducing the wattage or the power. We are just using water at the room temperature around the tip of the electrode so that the temperature don't go beyond 60 degree. So that is why we are keeping the power high so we can get a higher or a larger size of the lesion around 10 to 12 millimeter. So the tip is controlled with the circulating cold water at room temperature, and a larger size of lesion can be achieved. So what are the advantages of cool RF? So as I have already mentioned, larger lesion can be produced. So success rate is more. Even a new person can also do a RF procedure with a cool RF machine, because we are producing 10 to 12 millimeter size, while whereas we use conventional RF, the lesion size is only 2 to 4 millimeter, but here we are producing 10 to 12 millimeter size of the lesion. So while we are doing conventional RF, we have to be very, very precise, and it's very difficult for any person who is not well versed with this technique. Probably failure rate is high. But in case of cool RF, even a newcomer can also do this procedure with ease. And it is angle independent. We can come from any side to near to the target tissue. But there are some disadvantages of cool RF, like we can accidental motor nerve ablation can occur, and because we are using a large bore needle, so bleeding can occur, and it is expensive. Now here are some ways how we can increase the size of the lesion of the target nerve. So number one is increasing the gauge of the needle. We have various RF needle gauge, so 5 mm tip, 10 mm, 15 mm. So by increasing the gauge of the needle, we can increase the size of the lesion. Next is increasing the time using cool RF, using bipolar, and using newer cannulas like Venon cannula. We can increase the size of our lesion. Now, very important step is how we confirm, because we have to be sure we are not near any important structures. We should not damage any vital structure. So we have to be very, very sure our needle is near the target nerve or the pain generator from where the pain is arising. So then only we will get the result, and then only we can have the long-term pain relief. So image guided means we use ultrasound and C-arm to look at the nerve or the pain generator. Next, sensory testing is done with 50 to 100 hertz. So sensory testing is done to elicit the original pain. We will ask the patient if the patient is feeling the same pain, feeling the same sensation of the original pain. Then we are sure that our needle tip is near the pain generator or the target site. Then we do motor testing. So motor testing is usually done with 1 to 2 hertz. So we should not get any major motor nerve contraction while doing the motor testing. So if the major muscles are contracting, we have to reposition the needle. Otherwise, we might damage the motor nerve, and it might be sometimes catastrophic. Next one is sensory motor dissociation. So what is sensory motor dissociation? So suppose we are stimulating with a certain pulse. We are stimulating the sensory nerve. By doubling the pulse, we are not getting any motor nerve contraction. That is called sensory motor dissociation. Now, near-term list where we do conventional radiofrequency ablation for chronic pain management. So, conventional radiofrequency ablation is done usually in this gastrian ganglion, sphenopalatine ganglion, third occipital nerve, cervical facet, T2, T3, splenic nerve ablations, lumbar sympathetic and lumbar facets. So this is the list where we do regularly conventional radiofrequency ablation for management of chronic pain. Next, pulse RF has a very limited use. So here what we use, this is the list where we use pulse RF for chronic pain management. In occipital neuralgia, we use pulse RF. Suprascapular nerve in the frozen shoulder, we use very regularly suprascapular nerve because it's a motor nerve. So we cannot use this conventional one. So we might ablate the motor nerve, and so that is why we use pulse RF in case of suprascapular nerve denervation, in case of frozen shoulder and any other sort of pain. Next one is cervical dorsal root ganglion. In case of cervical radiculopathy with prolapsed intervertebral disc in the cervical region with cervical radiculopathy, so pulse RF of cervical dorsal root ganglion gives a very long-term pain relief. Next one is intercostal nerve ablations is done with pulse RF. Now cool RF has lots of indications. Cool RF is usually preferred where we need larger size ablation, large nerve we have to ablate, like genicular nerve for knee is a very important indication for cool RF. Next, the lateral branch of sacroiliac joint pain, sacroiliac joint, and then articular branch of a hip joint, articular branches of shoulder and lumbar facet. So nowadays it is said that cool RF can be used anywhere in the body except anywhere in our body for all pain condition except trigeminal ganglion, because it's a very small nerve in a very small area. So we don't use cool RF in case of this trigeminal neuralgia. Otherwise we can use in any part of the body. So now this is my radiofrequency generator. It's a neurotherm radiofrequency machine. So this is another RF machine we use. So now I'll briefly explain 2 or 3 painful conditions or chronic pain conditions where we regularly do RF ablations. One is a lumbar facet joint denervation. So many times probably you people also have noticed a person, especially with the elderly age group with a back pain, surgery is done very nicely, very accurate surgery with a very good center. The patient is still having back pain, elderly group, because the patient had the MRI with the cervical lumbar disc prolapse, and the patient had back pain, especially pyramidal back pain. The surgeon has done surgery, excellent surgery, still patient is not getting relief from that back pain. So these are the very common patients we usually get. So probably the patient had lumbar facet joint pain, and probably it was misdiagnosed by just seeing the MRI. The person who has done the surgery probably is misdiagnosed. That is why the patient is not getting relief. Surgery was perfect, but the diagnosis was not perfect. So this is one of the very common patient we get in our pain clinic. So how lumbar facet denervation is done? The patient usually give a history of paramedian back pain, and we evaluate clinically, and after that we go for diagnostic medial branch block. So diagnostic medial branch block is a very beautiful procedure where we can pinpoint, we can diagnose any painful condition just giving the local anesthetic 1% lignocaine 0.5 to 1 ml around that nerve, and the patient gets pain relief up to 60 to 80%, then my diagnosis is accurate. Probably the patient had this lumbar facet arthropathy. So next I'll go for lumbar facet joint denervation. So this is if anybody is doing any pain procedure, so this is a very common picture. So it's a familiar picture. So this is fluoroanatomy, fluoroscopic view of the lumbar spine in the ipsilateral oblique view. So this is, we also call it Scotty dog. This is what we call Scotty dog appearance, and this is the eye of the Scotty dog, this is the ear of the Scotty dog. So for diagnostic lumbar medial branch block, we will target this. 2 minutes. So this is the eye of the Scotty dog. So we will target here to do the diagnostic block. And for radiofrequency ablation, we will target this junction between transverse process and the superior articular pillar where there is a groove. So how it is done? So needle entry is 1 segment below and lateral to the target site, and then because we are doing conventional RF, my needle has to be in parallel to the nerve or the target tissue or the pain generator, whatever you say. Then 20 gauge 10 centimeter 5 mm active tip curved RF needle is placed. Again, this is the sensory stimulation, motor stimulation is done, and 3 cycles of radiofrequency ablation 90 second at 80 degrees Celsius is done by just rotating the needle, and my procedure is complete. So this is the target in fluoroscopic view. So this is the final needle position of lumbar facet joint denervation. You can see here in the picture. So next one is Gesserian ganglion radiofrequency ablations. So I'll quickly go through this. So commonly we do it for trigeminal neuralgias. Trigeminal neuralgia is also known as a suicidal disease because we get very many patients who is having the tendency, because pain is so severe and so excruciating. So in younger patient opt for this neurovascular decompression, but the majority of patients, they cannot go for neurovascular decompression. So only option is radiofrequency ablation of this Gesserian ganglion for this trigeminal neuralgia, and it gives excellent pain relief. So how we do RF ablation of trigeminal nerves? So usually it is done in the submental view, approximately 30 degree caudal and 30 degree lateral, and entry point is usually 3 cm lateral to the angle of the mouth, and needle is directed toward the foramen oval. If you find out the foramen oval, almost 80% work is done. Other part, any person can come and do the job. So the main difficult thing is the finding out in fluoroscopy the foramen oval, and the final needle position will be the direct angle formed by the clivus and the petrous temporal bone. So this is the position of the patient while doing this RF procedure for the trigeminal ganglion. So this is foramen oval, this is submental view, this is foramen oval, this is my target. So this is the angle between clivus and petrous temporal bone. This is the needle. So this is the final needle position for RF of trigeminal ganglion. So again here we do conventional RF. The sensory testing is done, again sensory testing, motor testing, and 3 lesion is done here. 65 degree for 60 second, 70 degree for 60 second, and 75 degree for 60 second. And always you have to check the corneal reflexes, because we might accidentally injure this V1 division. So this is a corneal reflex. Checking the corneal reflex is very, very important. So okay. So next one is suprascapular nerve. For suprascapular nerve, these are the indications. So suprascapular is the nerve, is the motor nerve. So we cannot do the conventional radiofrequency ablations. So here what we do is pulse RF at 42 degree Celsius. So this is the needle position. We targeted the suprascapular knots and the fluoroscopic guidance. So needle is, we have to place the needle perpendicular because pulse RF, as I have already mentioned, listen is done by the tip of the needle. So again, it is done in prone position with the arms at the sides. So body of the scapula can be touched in 2 to 5 centimeter, 2.5 centimeter, sorry, to 3 centimeter depth, and needle should be in the suprascapular knots. So again here, sensory stimulation, motor stimulation done, pulse RF, 42 degrees Celsius for 4 minutes. So radiofrequency ablation is also known as rhizotomy. It's a non-surgical, minimally invasive procedure that uses heat to reduce or stop pain transmission. It gives long-term pain relief for the patient with chronic pain. The benefit of radiofrequency ablation includes avoiding surgery, immediate pain relief, improved function, and a quicker return to work and other activities. Thank you.
Thank you. Thank you. Thank you, Dr. Bhoven Boru, for his very nice and elaborate topic. So one question is from me. Is there any specific contraindication with a patient with bleeding diastasis for radiofrequency ablation?
Yes. Before doing any these minimally invasive interventions, we always have to check the coagulation profile. If it is altered, we don't do, because there might be bleeding is one of the common complications of all these procedures. So if there is coagulation disorder is there, we don't do. Yeah.
My second question is, have you ever experienced any motor damage in your clinical experience?
No, motor damage I haven't in personal experience. I haven't, but in literature says there are lots of case studies. There are lots of cases we have seen. Even with the lumbar facet denervation, there paraplegia can occur if you are not place the needle accurately. Paraplegia might occur, but I haven't personally encountered anything.
Thank you.
I just have one question. Do you need a single sitting, or does it require multiple sitting, like to get the desired pain relief? Yeah.
Which RF?
This RF.
Which one you were mentioning?
I mean, any of this, like pulse.
Sometimes it requires, because RF ablation, it is usually, if it is done accurately in experts' hands, it will give pain relief up to 2.5 to 3 years. So it is a long time, 2.5 to 3 years. The patient is suffering from chronic pain since last 10, 15 years. 2.5 years to 3 years pain relief is more than enough. See, if it recurs, again we have to take a call. If the pain score is high, it might require another setting.
Okay, thank you.
Yeah.
Is there any precautions we have to take in patients with in situ electronic device? Supposing patient having pacemaker implanted, in such type of patient you are giving current, external current. That is there any precautions, special precautions we have to take, or how to manage in such type of patients?
Yeah. In case of the patient is patient have pacemaker, so we cannot do this unipolar RF ablation. In that case, we have bipolar radiofrequency ablation we can use, but unipolar we cannot use. Yeah.
And also, what is anticoagulation protocol that we follow in neuroaxial block? We should have to follow that one, or something else for different?
It is same. Okay. Same as for regional anesthesia what we are using. It's the same.
Okay. Thank you.
Thank you. Any question from audience? No. So we conclude the session. Very much thank you to Dr. Bhoven Boru for his nice topic.
sir, for your thoughtful session. Now we have a small announcement here. We are pleased to inform all delegates that dedicated hands-on stalls for peripheral nerve block stimulation and bronchoscopy have been set up at the exhibition center. We warmly invite those interested to kindly visit the stalls and explore the techniques. Thank you. Now I would like to call upon stage our next speaker, Dr. Apurva Kumar Bora sir. Sir is the head of the department Critical Care Medicine at Narayana Super Speciality Hospital, Amingao. Sir is also the president of IMA North Guwahati and the past general secretary of ISCCM, Guwahati branch. And sir has also been the editor-in-chief of many journals and has many national and international publications to his name. We warmly invite Dr. Apurva Kumar Bora sir to please come up on the stage and proceed.
Good afternoon, respected chairperson and audiences. My topic today is community-acquired pneumonia, and thank you, RAISACON, for giving me the opportunity to present in front of you. So I'll go very quick and to the point. This is a very common condition we all encounter in OPD, even IPD, ICU, a common condition. So, it is one of the most common infectious disease and important cause of mortality and morbidity worldwide. So, typical pathogen is Streptococcus pneumoniae, Haemophilus influenzae, and Moraxella catarrhalis. So, these are theoretically all over the world commonest organism with this condition. And prior to COVID-19 pandemic, the most common viral pathogen recovered from hospitalized adult patient admitted with CAP is human rhinovirus and influenza. So, presentation and pathogen in typical community-acquired pneumonia. So, term typical CAP refer to a bacterial pneumonia caused by pathogens such as already I have mentioned 3, and patient with typical CAP, that is community-acquired pneumonia, present with fever, productive cough, purulent sputum, and sometimes pleuritic chest pain. So, these are common presenting problem, and the most common bacterial pathogen overall is Streptococcus pneumoniae, although in some setting including the United States, its incidence is decreasing. So, if there is underlying chronic obstructive pulmonary disease, Haemophilus influenzae or Moraxella catarrhalis, these are more common. And if there is a recent influenza infection, Staphylococcus aureus or Streptococcus pneumoniae, these are common organism involved. And in alcoholic patient, you should think of Klebsiella. Klebsiella is growing in our part of the world. So you should think of Klebsiella event. So atypical community-acquired pneumonia is bacteria that cause atypical CAP, that includes Mycoplasma, Chlamydia, Legionella. Then if you see viruses, there are lots of viruses that can cause. And some rare bacteria that can cause CAP include Chlamydia, Coxella burnetii, and tularemia, Mycobacteria, and non-tuberculous Mycobacteria. Rare endemic fungi can cause subacute and chronic pneumonia. They include Histoplasma, blastomycosis, cryptococcus, and Coccidium immitas. So there are lots of fungus are also there. They are rare cause. So extrapulmonary sign and symptoms. This can be mental confusion, prominent headache, myalgias, ear pain, abdominal pain, diarrhea, rash, and non-exudative pharyngitis, hemoptysis, splenomegaly, relative bradycardia. These extrapulmonary signs and symptoms. And mycoplasma pneumonia is associated with the following findings. I'm going into direct few findings where you can suspect those atypical pathogen, like headache, fever, malaise, sore throat, erythema multiforme, and cardiac conduction abnormalities, hemolytic anemias, neurologic abnormalities like aseptic meningitis, and epidemic outbreak such as in schools and military barrack. But this can be associated with this atypical pneumonia. And in Legionella, you can suspect if you find the following findings like GI and neurologic symptom in setting of pneumonia, positive history of water or travel exposure, relative bradycardia, hyponatremia, hypophosphatemia, elevated CPK level, ferritin level, myoglobinuria, leukocytosis with relative lymphopenia, unresponsive to beta-lactam antibiotics. And if you see Coxiella burnetii or Q fever, you will find an acute infection, severe retrobulbar headache, myalgia, fever, rigor, non-productive cough, elevated levels of transaminase, thrombocytopenia, maculopapular purpuric rash, zoonotic exposure like goat, sheep, cattle, most common, right? So these factors are if associated, you can think of Q fever. So differential diagnosis of community acquired pneumonia, these are huge list, I'm not going into detail, but this will actually give you a clue. A clue can from history itself, clue can be from, history is the most important point here in different, differential diagnosis. So say for example, myocardial infarction. So those can be a differential even in pneumonia. So you need to be very good history taker. So history is always used to give a clue. Workup, very basic test, chest radiography, complete blood count with differential, serum blood urea nitrogen and creatinine level. This simple test should be there in workup. And for patient with severe case, patient being empirically treated for methicillin resistant, that is MRSA or Pseudomonas, or patient in whom a specific etiology is suspected, additional workup may be warranted. So these are the tests in special situation like sputum gram stain culture, blood culture, serum sodium level, serum transaminase, lactic acid, C-reactive protein, lactate, dehydrogenase, molecular diagnostics such as multiplex PCR, urinary antigen testing for Legionella. So these will come in specific situation. And during influenza season, molecular assay for influenza, molecular antigen testing for COVID-2, serological studies for Mycoplasma, Coxiella, Bordetella pertussis. This is all in specific situation. CPK and serum phosphorus level. Serum phosphorus level is actually very closely associated with Legionella infection, hypophosphatemia. And hypophosphatemia with pneumonia actually directs to a very bad outcome, severe disease. Hypophosphatemia associated with a very severe disease. And it can give a clue to Legionella disease. That is what why phosphorus level is important. So hospital admission, that is decided on severity. Severity we can assess by, there are lots of score like PSI, CARB 65. So this can be used. Now IDSA and ATS community acquired pneumonia guidelines define severe pneumonia as having one major or three minor criteria. So major includes septic shock requiring vasopressor, respiratory failure requiring mechanical ventilation. These are two major, and those are minor criteria. So one major or three minor. That means it's a severe community acquired pneumonia. Antibiotic therapy, directly coming into antibiotic therapy, outpatient treatment for CAP in patient with no comorbidities and no risk factor for drug resistant is amoxicillin 1 gram is enough. Or it is, kindly see, it's an important point, it is amoxicillin or macrolide or a doxycycline. It's not and, any one of this. If there is no, this is OPD treatment. Now, patient with comorbidities such as chronic heart, lung, liver, renal disease, diabetes, alcoholism, malignancy, asplenia, immunosuppression, prior antibiotics within 90 days, risk factor for drug-resistant infection, then your empirical antibiotic choice is slightly different. They said beta-lactam amoxicillin clavulanate or cefodoxime or cefuroxime, and now here come and the macrolide or doxycycline. So here two drugs will be used if there is patient having comorbidities, right? These all factors, and respiratory fluoroquinolone. So in this situation, two drugs. One is this and doxycycline, macrolide or respiratory fluoroquinolone. Here levofloxacin, moxifloxacin, they have mentioned in IDSA guideline. Hospitalized patients, those who are not in ICU, this is what group of patient. Here choice is same, beta-lactam, ampicillin, sulbactam, ceftriaxone, cefotaxime, ceftaroline, and the macrolide or a respiratory fluoroquinolone. If macrolide and fluoroquinolones are contraindicated, beta-lactam as above and doxycycline. So doxy is there in hospitalized patient. Now in ICU patient, same ampicillin sulbactam or ceftriaxone or cefotaxime or ceftaroline and the macrolide or respiratory fluoroquinolone. And patient with severe beta-lactam allergy, aztreonam may be substituted for a beta-lactam. If MRSA is suspected, then vancomycin and linezolid. These are, any one of these can be considered, because MRSA is emerging back. It is actually coming in even in community acquired setup also. If pseudomonas is suspected, then your choice is piperacillin tazobactam or cefepime or ceftazidime, meropenem. These are your choice. Aztreonam. Although IDSA guidelines for CAP include ceftaroline, this is 5th generation cephalosporin as a part of empirical beta-lactam therapy for inpatient. It is often reserved for patients who have risk factor for MRSA, because ceftaroline has MRSA coverage also, right? But ceftaroline actually in India, I think it is launched, it is available now only. During influenza season, empirical antiviral treatment is also advised for any patient presenting with flu-like symptom and pneumonia. However, oseltamivir is preferred for inpatient due to limited data on alternative antiviral in severe cases. So this is a slide which actually should guide you for empirical treatment of your center. So this is ATS guideline, but you do not need to follow ATS all the time. They have given you the backup, the skeleton they have given you. So best way to give antibiotic is to make your own hospital antibiogram, and based on that you can choose the agent, and that will become the antibiotic policy. Say for example, in our setup, in my hospital, the commonest organism even in community acquired pneumonia is Klebsiella. This is common, not Streptococcus. So in my hospital it is Klebsiella, it's not Streptococcus. So this is the base policy actually. Now duration, what is the duration? They said, IDSA said standard duration for uncomplicated CAP is 5 days. For CAP due to suspected or proven Pseudomonas or MRSA, duration is 7 days. This is typical duration, which cessation after patient has been afebrile for 48 to 72 hours and shows no signs of instability. Immunocompromised patients with CAP are treated similarly to otherwise healthy hosts, but may require a longer therapy duration and additional investigation into pathogen. So these are other antibiotics approved by FDA. So these I think is not available in India. These are name only. Omadacycline is a new tetracycline, and lefacmolin. So new macrolides are coming, delafloxacin, ceftabiprole. So those they have approved by FDA for use in community acquired pneumonia. Now coming to ICMR guideline, this is our guideline. It is almost same like IDSA. Only one point they say steroids are not recommended for use in non-severe CAP. So this is one point, but new studies they are coming up with which showing use of steroid in severe community acquired pneumonia with a good mortality benefit. So vaccination is very important. It prevents. Thank you.
Thank you, sir, for your nice and elaborate explanation on that topic. Any question from the audience? So there is no question from the audience. So we conclude the session. Thank you, sir.
Thank you. Thank you.
Thank you, sir, for the informative session. Now we would like to call upon stage our next speaker, Dr. Ashok Bansal, sir. Sir is the Senior Divisional Medical Officer and Head of Department Anesthesia in the Northern Railway Divisional Hospital, Delhi. Sir is a dedicated and experienced medical professional with over 10 years of experience in anesthesia and pain management. Currently heading the anesthesia department at Northern Railway Divisional Hospital, Delhi, and running a specialized pain clinic since 2018. Sir has expertise in managing all type of chronic pain conditions with a focus on improving patient quality of life through evidence-based anesthesia and pain relief techniques. I warmly welcome Sir to start with his proceedings.
Hello, good afternoon, and myself Dr. Ashok Bansal. Thank you, conference organizer, for giving me opportunity to speak on this topic. Before proceeding for my topic, I want to give some scenario. Like a 28-year-old male football mid-athletic is running missing from 12 days tournament because he has history of chronic patellar tendinopathy, having a illicit pain on anterior part of the knee, which does not responding to any physiotherapy and short duration of NSAID. His MRI is showing there is a intertendinous changes on anterior pole of knee. What to do now? If we use corticosteroid, which can risk tendon strengthening in such a athletic person, and if we use surgery, then he will be missing from the tournaments. So in this prospect, PRP has captured the attention of sports medicine worldwide. Today I want to give some highlights where to PRP can be used or where cannot be used. Let's start with PRP. PRP is a platelet-rich plasma. It is an autologous concentration of human platelet, as it is obtained from patient blood itself. In it, we concentrate plasma platelet concentration 3 to 5 times the normal baseline. PRP, the magic lies behind the not in platelets, but what platelets carry. It carries alpha granules, which release many growth factors like platelet-derived growth factor, like vascular endothelial growth factor, IGF, and endothelial growth factor, fibroblast growth factors. So the magic lies behind. Now, how to prepare the PRP? For preparation of PRP, there is we draw blood from antecubital fossa, 50 to 60 ml. Take this blood in a vial containing ADCP, which prevent the pre-release of platelets, activations of platelets. Then we centrifuge the platelet concentrate. First we give a short spin of 2500 to 300 rotation per minute and separate the component. In upper part there is a serum which is devoid of RBCs. Now we further give a hard spin. Hard spin is 2500 to 3000 rotation per minute, and then there is a formation of buffy coat layer concentrate, and after this the upper layer which contain serum devoid of platelets, and the lower layer contain platelets. These platelets concentrated 2 to 4 ml. Now we take this in our syringes, and before implication we add calcium chloride or thrombin for the activation of the platelets. Now we introduce inject them. Now mechanism of action. Mechanism of action can be divided into 3. First is the proliferation phase. First is the activation phase, and then there is the proliferation phase, and the last one is the modulation phase. When we give PRP substance, there is a activation of the platelets which release alpha granules. Alpha granules containing platelet-derived growth factor. Platelet-derived growth factor is responsible for cell proliferation and tissue repair. Similarly, epidermal growth factor, which is responsible for cell migrations and differentiation, and a transforming growth factor, which is responsible for collagen synthesis and anti-inflammatories. Vascular endothelial growth factor is responsible for angiogenesis and blood supply. IGF, insulin-like growth factor, is responsible for muscle and cartilage regeneration. And fibroblast growth factor is responsible for wound healing and bone repair. Now the whole process takes approximately 6 weeks to get a better outcome. I like to do some enter into it. In first phase, there is a formation of increase in the proliferation of the cells occurs. Then there is a formation of type 3 type of collagens occurs in the polyphasic phase, and in later phase type 3 collagen is converted to type 1 collagen, which provides strength to the cartilage. Now what various type of sports injury which can be helpful is tennis elbow. In lateral epicondylitis, most evidence-based PRP use single injection shows 45 to 84% success rate, better than corticosteroid at 6 to 12 months. Knee ligaments like ACL and MCL repairs, tears, use post-surgery to enhance graft integration and healing, reduce recovery time by 30 to 40%. In Achilles tendon tendinopathy, chronic Achilles tendinopathy responds well 2 to 3 injections at 4 to 8 intervals and returns athlete to sports faster. Similarly, patellar tendon in jumpers for knee, rotator cuff injury and hamstrings injury in grade 1 and 2 tears reduce healing time in professional athletes, early return to play without compromising the tissue qualities. PRP in orthopedic conditions like osteoarthritis, grade 1 to osteoarthritis show best result. Fracture, non-union like tibial and femoral union, applied at fracture surgically, simultaneous callus formation and reduce healing time significantly. Used with bone grafting procedures. Post-surgical recovery after TKR and THR procedure, reduce post-op pain and swelling, faster return to mobility, applied intraoperatively, decrease infection risk. Clinical evidences and success rate, 84% cases of tennis elbow has a good success rate, 70% of osteoarthritis has very good improvement, and 65% in ACL recovery has a better relief. 78% get properly patient satisfied. Now PRP versus conventional treatment. If we use corticosteroid, immediate pain relief is excellent, but long-term outcome is poor. Tissue healing is less. Side effect is multiple and number of sessions is many. Similarly, physiotherapy, longer outcome and tissue healing is better, but in case of PRP, long-term outcomes, tissue healing and side effects all are best. PRP procedural protocol. In pre-procedure, we take CBC, platelet and baseline. We stop NSAID 1 week prior. Patient consent and counseling should be taken, and imaging for injection guidance and informed about 2 to 3 sittings. Now procedure, we draw 15 to 60 ml of venous blood, double spin centrifugation done, separate PRP layer carefully, activate with CaCl2 if needed, and inject under aseptic condition. Post procedure, rest area for 30 minutes, avoid NSAID for 2 to 4 weeks, ice application for pain, and then physiotherapy after 48 hours, follow up 2 to 6, 12 weeks up to. Now what are the contraindication and safety profile? Contraindicated in patient having platelet dysfunction syndrome, thrombocytopenia having platelet count less than 1 lakh, active infection at infection site, systemic infection and sepsis, patient is on anticoagulation therapy, hemodynamically instability, active malignancy or cancer history, pregnancy or insufficient evidence, anemia like less than 10 gram per deciliter. Safety profile. Autologous has 0 rejection risk, no systemic side effect, local pain at injection site for just 24 to 72 hours due to needle prick. Temporary swelling and stiffness may be possible. Rare infection in very less case. no allergic or immune reaction, no decreased transmission risk, rare nerve irritation if improperly injected, and overall complication rate is less than 2%. PRP in special population like elite athletes, widely used in professional sports like cricket, football, athletics, diabetic patient, impaired wound healing improved by PRP, growth factor compensate for reduced natural healing and combined with standard diabetic wound care, and in elderly and osteoarthritis grade 1 to grade 1-3 knee osteoarthritis with excellent result. Post-surgically applied during ACL reconstruction, rotator cuff repair, enhanced graft healing and vascularization. Conclusion, PRP is a safe, autologous and evidence-based, effective in tennis elbow, knee osteoarthritis and tendinopathies, accelerate athletic recovery and return to sports, and superior long-term result versus corticosteroid. Regeneration, not just symptomatic relief. Thank you.
You have mentioned there is a process, first blood draw, then centrifuge, then activation, after that infuse. So calcium chloride is added for what purpose?
Actually, platelet need to be degranulate. For degranulation, we use CaCl2 or thrombin. And if you don't want to add, you can directly inject into tissue. Tissue itself is a stimulating factor for the triggering of the release of the alpha granules.
Okay. Then ultimately we increase the growth factor or what?
Yeah. Growth factor at injury site or.
Okay. So is there any contraindication for calcium chloride to be added in particular patient as it is an optional process?
It is not essential that you need to be added CaCl2.
No,
if you don't want to add, you can directly inject it because tissue environment is itself triggering for the release of the alpha granules.
Okay, is there any contraindications in some patients where we cannot add calcium chloride?
If patient is suffering from hypercalcemia. Hypercalcemia.
Okay. So it has been mentioned somewhere that in peripheral arterial diseases where we have to avoid calcium chloride or we have to check platelet count before giving calcium chloride because it will aggravate clotting and which will lead to peripheral arterial disease more serious.
If patient is suffering from some coagulopathies, then we have to identify all these things. I have earlier also told that it is a related contraindication in patient suffering from platelet dysfunction or coagulopathies.
Okay.
If blood sample from a different person, not from the same patient, can be used for
yes,
PRP?
We can use.
Any precaution we have to take for it?
But we have to take consent first. And I have done some heterologous also, and they have get better result. But we have to inform earlier. Okay, this is a heterologous sample. If patient is not able to provide that sample due to some problems.
Okay. And is PRP and corticosteroid can be used simultaneously for a better outcome?
Sir, actually corticosteroid is responsible for weakening of tendon. If we use simultaneously, then my purpose of making risk of tendon strength is already there. I am using platelet-rich plasma PRP because I does not want to weaken the tendon strength. That's why if we use simultaneously, then I think it's better not to use simultaneously.
Thank you. Any question from the audience?
Cannot use one is anti-inflammatory and PRP we are giving it heals by causing inflammation in cities. So steroids and PRP combined, big no.
Yes. Yes, sir. I have already given we have to stop NSAID before the before procedure of PRP. Yes. Thank you.
Thank you.
Thank you, sir, for your informative work. And with this, we come to the end of our third session. So, with the due permission of our respected chairpersons, I would like to conclude the session. I request our chairpersons, Dr. Abhinav FORE sir, Dr. Jasper Mar ma'am, and Dr. Jyoti Sundar sir, to please proceed to the felicitation podium for the felicitation ceremony. And I request our speakers, Dr. Bhavan Chandra Bora sir, Dr. Apurva Kumar Bora sir, and Dr. Ashok Bansal sir, also to proceed to the felicitation podium for the felicitation ceremony. And I also request our respected chairpersons to please felicitate our speakers. And I request Dr. Bhumar Bole sir to please felicitate our respected chairpersons. I would like to start with the next session. To begin with, I would like to call upon stage our respected chairpersons, Dr. Frank Anwar sir, ACMS Palakkad anesthesiologist and sir, area of interest is pain management. I request sir to please come upon the stage. Next, I would like to call upon the stage Dr. Basmati sir, ACMS physician learning. I request Dr. Basmati sir to please come upon the stage. And I would also like to call upon the stage Dr. Krishna K. ma'am, Senior DNR Physician, Central Rural Hospital, Maligaon. I request ma'am to please come upon the stage and share over the next session. ये निकालो. Permission of our respected chairpersons, I would like to call upon stage our next speaker. So, I would like to call upon stage Dr. R. Prasanna Kumar, our next speaker. Sir is Senior DMO Anesthesia and Critical Care, Railway Hospital, ICF, Chennai. I request Dr. Prasanna Kumar sir to please come upon the stage and proceed with his slides.
Hello. Yeah. Shall I start? Yeah. A very good afternoon to one and all. At the outset, I'd like to thank the organizers, especially Dr. Ravi Kiran and Somnath Chadha sir, for giving me this opportunity to present this topic. And my special regards to the entire team of NFR for organizing this conference in a very grand manner. I'll be talking about trauma prophylaxis evidence-based guidelines, especially concerned to ICU, intensive care unit, and I have been asked to complete my presentation within 15 minutes as we are running short of time. I'll try to do my best for that. Sorry? Sound. Okay. So there is no conflict of interest and there is nothing to disclose, and I will be discussing the guidelines given by IACCM, that is Indian Society of Critical Care Medicine, and American College of Chest Physicians, and the comprehensive highlights of American Society of Hematology. So I start my presentation with this quote, which means that true ambiguity is better than inaccurate certainty, which is the base of any evidence-based protocol. we all know that VT is venous thromboembolism is one of the preventable cause for mortality in any ICU. Most often it is suspected rather than diagnosed. What does it mean? By the time we diagnose a patient with pulmonary embolism, most of them die, and very often we declare the patient stating that it is a suspected case of pulmonary thromboembolism, and the mortality has been reported to be as high as 80% in some centers. So that's why venous thromboembolism prophylaxis is very crucial in any critical care unit. The incidence globally has been reported to be 4 to 15%, but exact incidence is not clearly known because of the heterogeneity of the patients getting admitted in ICU. Secondly, there are various different protocols has been followed by different ICUs, and screening as well as treatment protocols are different in different ICUs. So the incidence is clearly not known. When we look into the Indian data, this is one excellent paper that has been presented by CMC Vellore Chennai and CMC Vellore Tamil Nadu. They found the incidence of venous thromboembolism to be as high as 17%. CMC Vellore is one center which has very high protocol-based management. You can just imagine the volume of the disease. When an institute with high protocol is having an incidence of about 17%, then you can just extrapolate it to other ICUs which doesn't have a clear protocol. This is one landmark trial that has been published in 1960. Before that, we didn't have a clear guidelines for managing patients with VTE, and there was no prophylactic guidelines given for thromboprophylaxis. But after this trial was published, a lot of guidelines came into practice. This is one very important landmark trial. About 35 patients were recruited for this study, of which 19 patients did not receive anticoagulants, whereas 16 patients received anticoagulants. Of the patients who did not receive anticoagulants, 5 had pulmonary thromboembolism and 5 had non-fatal recurrences, whereas the patients who received thromboembolism anticoagulants, none of them had event of pulmonary thromboembolism, and there was no recurrence as well. This is published in Lancet in 1960. When we look into the evolution of guidelines, before 1980 there were no guidelines as such, so venous ligation and air mobilization were the only options available for prophylaxis. Later on in 1986, that is American College of Chest Physicians, they came up with a guideline for thromboprophylaxis in general population, both medical as well as surgical patients. They have updates in 2001, 2012 and 2021 as well. Now, the recent guideline is being given by in 2018, American Society of Hematology. They also gave a guideline for thromboprophylaxis, but none of them gave a clear-cut guideline for managing patients in critical care. Whereas Indian Society of Critical Care Medicine in 2022, they came up with a consensus guideline for thromboprophylaxis in ICU. So I will give you a brief review of the guidelines given by ISCCM account. So the guidelines was framed basically by 11 panelists by leading institutes from Maharashtra. They had meta-analysis giving emphasis to large RCTs, smaller RCTs, and RCTs which is done in non-ICU setting were excluded from the guidelines. Recommendations were strictly restricted to adult population only, so the guideline doesn't recommend thromboprophylaxis for pediatric patients. The primary outcome for all these trials was symptomatic DVT, symptomatic pulmonary embolism, and mortality due to venous thromboembolism. So I will be discussing the guidelines in 3 different categories. One is risk stratification, followed by choice of prophylaxis, and prophylaxis in special considerations. So first thing is risk stratification. This is the base for thromboprophylaxis in ICU. So we have to assess the patient at risk, whether the patient is at risk of thrombosis or the patient is at risk of bleeding. This is the first and primary foremost thing that we have to do in any critical care setup. We have a lot of scoring systems available. The Capillary score is specifically used for surgical patients. The PERVA and the improved scores have been recommended for medical patients, but none of them have been approved or have been evaluated for patients who are critically ill. So I have just displayed, I am not getting into the details of the scoring system. The PERVA score has been recommended by American chest physicians, and the improved score has been advocated by American Society of Hematology. So moving on to risk stratification for bleeding, we have 2 scores, there is RISE registry score and the improved scoring. Once again, improved scoring has been advised by American Society of Hematology. So the first recommendation for risk scoring is that all critically ill patients in ICU should be considered at moderate to high risk of DVT. So any patient who enters the ICU, we consider them as moderate to high risk of DVT, and this has been strongly recommended by all the 11 panelists. But what they suggested is they are unable to recommend any specific scoring system. I showed 2-3 scoring systems in my previous slides. So they don't recommend specific scoring system or cutoff for risk stratification of patients in ICU, because all these has not been fully evaluated for patients who are admitted in critical care unit, whereas they are given a list of high risk situations where thromboprophylaxis is strongly recommended. So I've just enlisted this like mechanical ventilation, use for vasopressors, platelet transfusion, use of central venous catheter. Of all these and high risk things, use of central venous catheter has the highest risk of venous thromboembolism. That is what the study from CNC Bangalore has finally projected. So all patients admitted in ICU should be evaluated for bleeding. So first we are assessed for thrombosis. Similarly, for bleeding, all critically ill patients should be assessed for risk of bleeding. The strong recommendation given by 11 or all the 11 panelists. And once again, there is no validated bleeding risk scoring that has been recommended by the panelists for evaluation of bleeding. So the panel recommends a complete comprehensive evaluation using history, clinical examination, and investigations as and when required. So the choice of thromboprophylaxis, we have two broad categories. One is pharmacoprophylaxis and second is mechanical prophylaxis. In pharmacological prophylaxis, we have parenteral and oral. In parenteral, we have unfractionated heparin, low molecular weight heparin, and fondaparinux. Where oral drug, we have vitamin K antagonist and directly acting oral anticoagulants. In mechanical prophylaxis, we have IPCs, that is intermittent pneumatic compression devices, and graded compression stockings. So the recommendations for pharmacoprophylaxis is that all critically ill patients should receive pharmacoprophylaxis for DVT prevention if there is no other contraindication. This has been recommended by 8 of the panelists, and 3 chose to give conditional recommendation due to non-availability of convincing clinical outcome data. The panel recommends using either unfractionated heparin or low molecular weight heparin or fondaparinux for DVT prophylaxis. This is something different from American Society of ASH guideline. I'll just discuss it later. Strong recommendation has been given by 7 panelists, and remaining 4 panelists gave a conditional recommendation. And these are the drugs and doses that has been advised by the panelists. Directly acting oral coagulants are not preferred in critical care setup, because most of the patients are critically ill, oral absorption will not be good, and we have to severely monitor the bleeding profile. So for all critically ill patients, low molecular weight heparin is preferred over directly acting oral anticoagulants. This has been strongly recommended by 9 panelists. The reason why it is not being recommended is that none of the studies have evaluated the role of directly acting oral anticoagulants in ICU patients, and there is a paucity of evidence to suggest the role of these drugs in venous thromboembolism prophylaxis. Moving on to mechanical prophylaxis, the critically ill patients who cannot receive pharmacological prophylaxis should be put on mechanical methods of thromboprophylaxis. This has been strongly recommended by 8 of the panelists. Remaining 3 panelists gave a conditional recommendation. Regarding the choice of mechanical prophylaxis, we have 2 choices, one is IPCs and the graded compression stockings. Studies have strongly proven that intermittent pneumatic compression devices are far better than graded compression stockings, and moreover, graded compression stocking, there is a high risk of pressure ulcers, and the efficacy is also too low. So that's why IPCs, intermittent pneumatic compression devices, are recommended in comparison to graded compression stockings. Combined prophylaxis is not being recommended, is not routinely used for any patients in ICU. This is based on the PREVENT trial, which I showed not a significant reduction in the incidence of thromboprophylaxis or DVT in patients in ICU. So the duration of prophylaxis, VT prophylaxis should be given until the patient is getting discharged from the ICU. The clear duration is not clearly fully evaluated, and the degree of ambulation is also not clearly known. So it is, as of now, it is recommended to give thromboprophylaxis till the patient is admitted in ICU, and there is no role for extended prophylaxis using directly acting oral anticoagulants in ICU. IVC filters, once again, routine placement of IVC filters is not recommended by the panelists. This is being strongly recommended by all the 11 panelists because of the potential complications of DVT, IVC thrombosis, etc. Regarding mobilization, the panel recommends early mobilization as early as possible when the patient has fit into the criteria of mobilization. You have to mobilize the patient as early as possible. This is strongly recommended by 9 panelists. Mobilization, even in the presence of DVT, will reduce the pain and edema. Regarding the cannulation site, this is very important. Subclavian vein is the preferred site for IVC cannulation in any ICU as far as high risk of thrombosis is concerned. Second site would be the IJV followed by femoral vein. This is based on a lot of 4 large multicentric studies which showed that risk of thrombosis was much less with subclavian vein cannulation compared to IJV. And one more thing is that left-sided cannulation has a higher risk of thrombosis as compared to right-sided cannulations. Moving on to special conditions like trauma, the panel recommends initial use of mechanical prophylaxis for the first 3 to 4 days, followed by chemical pharmacoprophylaxis as early as possible, as early as 24 to 48 hours of trauma, after assessing the risk of bleeding. This is strongly recommended by 7 panelists. Moving on to critically ill surgical patients, the panel recommends early use of unfractionated heparin or low molecular weight heparin in critically ill surgical patients. Mechanical prophylaxis should be used only if the risk of bleeding is very high after surgery. This is strongly recommended by all 11 panelists. Post cardiac surgery, once again, initiating for mechanical prophylaxis for the first 24 hours. After that, within 24 to 48 hours, we have to restart thromboprophylaxis with pharmacological drugs like low molecular weight heparin or unfractionated heparin. The incidence of cardiac tamponade and high risk bleeding, reopening is all like comparable with when we are not getting prophylaxis. So that's the reason why they recommend thromboprophylaxis after cardiac surgery as well. The incidence of VTE in sepsis is quite high, is as high as 12 to 13%. So all patients who are suspected or having sepsis should be on chemoprophylaxis as early as possible. This is strongly recommended by all the 11 panelists. In renal failure, it's still a controversy. So first we have to assess the risk of bleeding. Unfractionated heparin is preferred over low molecular weight heparin. This is strongly recommended by 11 panelists. Regarding heart failure, all patients with heart failure with low risk of bleeding should receive low molecular weight heparin. This is being strongly recommended by 9 panelists. Just 2 more minutes, please. Neurological condition, both ischemic and hemorrhagic stroke, still it is not very clear. Only 3 panelists have recommended. Mechanical prophylaxis preferred over pharmacological prophylaxis. In pregnancy, all critically ill pregnant patients should receive thromboprophylaxis in the form of low molecular weight heparin or unfractionated heparin. This is also being strongly recommended by all 11 panelists. So in COVID-19, we all know it is a high risk, is a prothrombotic condition. Once again, pharmacoprophylaxis is recommended by all 11 panelists. So this is the ASH guideline. It's all same as that of Indian guideline. Only difference is that in Indian guideline we recommended both unfractionated as well as fractionated heparin, whereas here in ASH guidelines they gave preference to low molecular weight heparin over unfractionated heparin. So this is the American College of Chest Physician guideline. Here the difference is that they used the Pavlov score and the improved bleeding risk score, whereas in Indian guideline we don't have specific scoring system. Instead we give a list of risk factors. Presence of one or more than one risk factor should be considered as a very high risk of thromboembolism, and then we should start prophylaxis. So to summarize, risk stratification, assess the risk of bleeding and thrombosis. If there is no contraindication, go for low molecular weight heparin. Unfractionated heparin if the clearance is less than 30 ml per minute. If there is risk of bleeding, go for mechanical prophylaxis. Early ambulation is the key factor. Continue prophylaxis until the patient is getting discharged from the ICU. So I end my topic with this another Murphy's law. Anything they say that anything that can go wrong will definitely go wrong. It means that when there are a lot of possibilities, the worst possible thing can happen, will always happen. So always it is better to have prophylactic protocol in hand to prevent a complication. Thanks a lot.
Dr. Prasanna, very nice, lucid presentation. What investigation do you do when a post-TKR patient develops edema of foot?
So there is like we don't have a specific guideline for investigation as such. So we have to consider clinical evaluation when there is a risk of thrombosis. When you are expecting that the patient is at high risk of thrombosis, the first thing that they recommend is to do a D-dimer. Because that will rule out the other possibility. Like if D-dimer is normal, then we need not investigate further. We need not go for a VT scan, or we need not go to investigate for a CTA for pulmonary embolism. So initial bedside for screening test for DVT would be to do a compression ultrasonography, which is a bedside simply available in all ICUs, that is recommended by the panel. So we can do a compression ultrasonography at bedside, that will rule out DVT. When you suspect pulmonary thromboembolism, the initial diagnosis, initial investigation would be to do a D-dimer.
Okay, do you do a pre-operatively D-dimer? Routinely for DK operation?
No, there is no necessary. It's not recommended. Routinely doing an investigation for risk assessment is not recommended.
What about if there is infrarenal clot? What do you do?
Sorry?
Infrarenal
clot.
You see it.
It is a therapeutic. It doesn't come under a prophylactic dose. If the patient has a pre-existing DVT, that becomes high risk for thromboembolism, then the patient should be on prophylactic. Definitely the patient should be on prophylactic low molecular weight heparin.
Do you recommend the IVC filter?
That's what I told you. So IVC filter is not recommended anymore.
But don't you think it can migrate up?
No, sir. That's what, sir. IVC filter has been found to have high risk of intravenous thrombus extension, high risk of thrombus, and all complications are more with IVC filters. There are very specific indications for IVC filter, like if anticoagulation, IV anticoagulation is not at all possible, and the other possible methods of mechanical prophylaxis also cannot be done, then it is an indication. Otherwise, routinely placing an IVC filter is not recommended by the panel or any guideline. That, for that matter, American College of Chest Physicians as well as ASH guideline doesn't recommend placing an IVC filter.
Thank you for your elaborate presentation. And though we have seen that all those patients who are requiring long-standing treatment in ICU,
yes,
they are to be given prophylaxis for deep vein thrombosis as well as pulmonary embolisms. Still, there is some set of patients, those who are to be given prophylaxis with very much caution, with precaution.
With precaution.
Yes. So, can you highlight in whose type of patient?
First step in assessing the patient is whether we will be assessing the risk, whether there is a risk of thrombus or there is a risk of bleeding. If the bleeding risk is very less, then definitely that patient is a candidate to go for a pharmacological prophylaxis. If bleeding risk is more, then for first 24 to 48 hours, mechanical prophylaxis is recommended, followed by reassessment. We have to reassess whether the patient is still at risk of bleeding or not. If the bleeding risk is comparatively less as compared to the previous assessment, then you can consider giving a pharmacological prophylaxis. So the guideline is pharmacological prophylaxis is the best. So whenever possible, we have to go for pharmacological prophylaxis. Assess the risk of bleeding. If bleeding risk is less, is more, then consider mechanical prophylaxis. So that's the recommendation.
One more question. What kind of prophylaxis would you like to suggest who are going to be operated? Say, cardiac operations or something like that.
Pharmacological prophylaxis is the choice, either low molecular weight heparin or unfractionated heparin, because they can be titrated just pre-operatively. Low molecular weight heparin usually stop 12 hours prior surgery, and unfractionated heparin, therapeutic doses 4 to 6 hours before surgery, you can stop and you can proceed with the surgery.
Thank you.
Thank you, sir, for such an informative presentation. Due to time constraints, only one or two questions from the audience.
Sorry, ma'am, I didn't get you. Take is not routinely done, ma'am. Only if you suspect bleeding.
Sorry.
It is not routinely done for evaluation of thrombolysis. It is not even given in the high risk for bleeding assessment as well. Take is usually not done routinely in any of the ICU setting. when there is a high risk of bleeding, and when you know the reason for the bleeding, whether that's excessive fibrinolysis or if it is due to thrombocytopenia, when you have that confusion, then there is some point in doing. Otherwise, routinely doing TEG is not indicated.
Thank you, sir.
In all old age hip fractures,
yes.
After admission, before surgery, we recommend anticoagulants.
Yes, sir. It depends upon the risk. If you are expecting the immobilization time to be more than 3 days, and if your expected surgery is more than 3 days, then it is better to start on pharmacological prophylaxis before surgery, and then integrate it according to the time of surgery. You can start either low molecular weight heparin or unfractionated heparin. Low molecular weight heparin is preferred because unfractionated heparin you need to give multiple doses, whereas low molecular weight heparin it is a single dose. Unfractionated heparin needs monitoring, OPT monitoring, whereas low molecular weight doesn't require that. So always low molecular weight heparin is preferred over unfractionated heparin, especially in the perioperative period.
Okay, thank you, Professor.
Thanks a lot.
Thank you, sir, for the session. Now, due to some technical glitch in the morning, we are running behind the scheduled time. So, I request all delegates to be patient and kindly cooperate with us. And I also request all the participants to ask any questions or any discussion to please continue it in the lunch time with the respective speakers. All RAISA members are requested to be present in the venue for the general body meeting and the oration of Dr. A.M. Rai, sir. Next, I would like to call upon our next speaker, Dr. Arati PP ma'am. Ma'am completed her MBBS from Mandya Medical College, Karnataka, and went on to pursue her MD in anesthesiology from Government Medical College, Calicut, Kerala. With a strong academic foundation and specialized training, she was recently embarked on her professional journey as an anesthesiologist. She is currently serving as an ADMO in the railways, where she is contributing to patient care with dedication and enthusiasm. As a young and dynamic professional, Dr. Arati brings fresh perspectives and a strong commitment to excellence in her field. I request Dr. Arati ma'am to please come up on the stage.
Sincerely thank the organizers for this opportunity to speak with the highly talented doctors of Indian Railway. And without much delay, I will move on to my topic. My topic is perioperative management of patients with diabetes mellitus. Diabetes mellitus is a chronic metabolic disorder characterized by elevated blood glucose levels due to impaired insulin secretion, insulin action, or both. If not properly managed, it can lead to serious complications affecting the heart, kidneys, eyes, and nerves. Proper management of diabetes in patients during the perioperative period reduces mortality and morbidity. History taking should include type, duration, and drugs. The severity of complications such as chronic renal failure, cardiovascular disease, autonomic dysfunction, and delayed gastric emptying must be noted. There is an increased risk of postoperative myocardial ischemia and perioperative mortality. Autonomic dysfunction can cause silent myocardial infarction. Uncontrolled diabetes is a risk factor for congestive heart failure, surgical site infection, and stroke. In physical examination, document vitals, including orthostatic vitals, and perform airway examination. Look for stiff joint syndrome and prior sign. Fundoscopy should be done for retinopathy. Regular investigations must include ECG, electrolyte, creatinine, blood glucose concentration, estimated GFR, FBS, ppbs and HbA1c. Additional investigation should be done depending on the comorbidities. Obtaining a preoperative HbA1c is recommended to assess glycemic control and identify patients with undiagnosed diabetes. American Diabetes Association recommends a target of HbA1c less than 7% for most diabetic patients in a non-operative setting. The WHO Surgical Safety Bundle suggests a target perioperative blood glucose concentration of 6 to 10 millimoles per liter, that is 100 to 180 milligram per deciliter. The goals of perioperative management are to avoid hypoglycemia, prevent ketoacidosis, and avoid marked hyperglycemia. An individualized plan should be made based on patient factors, surgical factors, and type of diabetes. Surgery should be preferably posted as the first case to avoid interruptions in glycemic management. Postponement of surgery should be considered in cases of marked hyperglycemia, that is RBS more than 250 milligram per deciliter, ketoacidosis, and hyperglycemic hyperosmolar syndrome. Oral hypoglycemic agent are the first line treatment. Newer drugs include sodium glucose transporter 2 inhibitors, that is dapagliflozin, empagliflozin, and canagliflozin, which provide cardiorenal protection. SGLT2 inhibitors offer superior heart failure protection. Glucagon-like peptide-1 receptor agonists like exenatide and semaglutide are associated with less hypoglycemia and weight reduction. GLP-1 receptor agonists also help in reducing atherosclerotic risk. American Diabetes Association recommends withholding all classes of oral hypoglycemic agents except SGLT2 inhibitors on the morning of surgery, while SGLT2 inhibitors should be withheld 72 to 96 hours, that is 3 to 4 days prior to surgery. There are differences of opinion among various guidelines, but I have mentioned the one approach to make it easier to remember and follow. Oral agents can be restarted once the patient resumes food intake. Insulin therapy. This table describes insulin therapy. Rapid-acting and short-acting insulin morning doses should be omitted and can be resumed once patient starts taking foods normally. Long-acting insulin such as glargine and detamir and intermediate-acting insulin such as NPH should be administered in reduced doses even during fasting. Intermediate-acting insulin, the usual dose is given evening prior and reduced by 50% on the morning of surgery. Long-acting insulin, if taken once daily in the evening, reduce the dose by 20 to 25% in the evening before surgery. And long-acting insulin, if taken in the morning, reduce the dose by 20 to 25% on the morning of surgery. In twice daily regimen, reduce the dose by 20 to 25% both the evening before and the morning of surgery. When the patient is receiving premixed insulin, that is a regular NPH in 30/70, it is preferable to switch to long-acting insulin in the evening before surgery. If this is not feasible, the premixed insulin dose should be reduced by 50% on the morning of surgery and dextrose containing intravenous fluid should be initiated. The normal dose can be restarted when the patient resumes normal food intake. If oral intake is poor, half the dose should be given. If the patient is not eating, only the basal component should be administered. Alternatively, the patient can skip the morning dose and arrive early in the preoperative area to receive a long-acting formulation before surgery. In surgeries lasting less than 4 hours with minimal fluid shift and stable hemodynamics, blood glucose can be managed with a subcutaneous rapid-acting insulin every 2 hours. In surgeries lasting more than 4 hours with significant fluid shifts and hemodynamic fluctuations, intravenous insulin infusion should be started to maintain blood glucose less than 180 milligram per deciliter. Always avoid hypoglycemia rather than hyperglycemia. Do not withhold insulin entirely in patients who are highly dependent on insulin, as this can lead to insulin deficiency and ketoacidosis. Although lower glycemic targets around 100 milligram per deciliter were previously suggested to avoid complications, recent literature recommends maintaining blood glucose between 6 millimoles per liter, that is 108 milligram per deciliter, and 10 millimoles per liter, 180 milligram per deciliter in the perioperative period. Variable rate intravenous insulin infusion therapy. It was introduced as a replacement for Albert's glucose insulin potassium regimen in 1990s. It manages hyperglycemia by continuously infusing fast-acting insulin. Example, Etranpir. maintain blood glucose between 6 to 10 milliliters per liter, 108.8 milligrams. It is commonly used in fasting, surgical, or acutely in patients. To prevent the rebound hyperglycemia and ketosis. Electrolytes should be monitored daily, and sodium containing fluids should be used if variable rate intravenous infusion, insulin infusion continues for more than 24 hours to prevent hyponatremia. Patients who are vomiting, febrile, or dehydrated may require additional fluids such as 0.9% sodium chloride. Variable rate intravenous insulin infusion should be discontinued only after subcutaneous insulin had been given with at least a 30-minute overlap. For insulin dose adjustment, total daily dose can be calculated as 0.3 units per kg in frail CKD and type 1 diabetic patients and 0.5 units per kg in other patients, or estimated from variable rate intravenous infusion insulin infusion. This can be converted into a premixed or basal bolus regimen. Continuous, this is the rate of variable rate intravenous insulin infusion. Continuous subcutaneous insulin infusion used in patients with a type 1 diabetes mellitus. It delivers a fixed hourly rate of rapid acting insulin as basal insulin. Patient can give bolus doses to match carbohydrate intake. It provides better glycemic control and reduces hypoglycemia compared to multiple daily injections. CPOC recommends continuous subcutaneous infusion in the perioperative period if fasting time is short, not more than one missed meal. However, dislocation of the pump and interference with the electrocautery should be monitored. Most user manuals state that these pumps are not specifically designed for use in the operating theatre. So in post-operative care, restart insulin timely and monitor glucose closely, and the aim is to prevent rebound hyperglycemia and ensure recovery and safety. So this is the post-operative insulin therapy. It is mainly based on basal nutritional insulin and correctional insulin. So to conclude, perioperative management of diabetes requires a thorough preoperative assessment, individualized treatment planning, appropriate insulin adjustment, continuous monitoring, maintaining optimal glycemic control significantly improves surgical outcomes and reduces complications. Thank you.
We'll break for lunch after this. If anybody has any question, one question.
Only one question.
Thank you, madam, for such a nice presentation. I want to know, in our student life, we used to follow the D-GAMI regime. D-GAMI regimen, during the operative procedure, we used to give glucose infusion along with insulin and potassium. So what about that?
Sir, that is variable rate intravenous infusion. We recently now we are following that one. Like if the infusion, insulin infusion is lasting more than 24 hours, then we can add glucose and potassium depending on the electrolyte. Regular use of the GIK regimen is now not that much recommended because it will that potassium, because of the potassium level. So first monitor the potassium level. Only it this GI means potassium and other glucose should be added accordingly to the electron, depends on the electrolyte.
Thank you.
Thank you, sir. Thank you.
I request everyone to be please seated for the oration. I request everyone to be please present in the venue for the oration coming next. So with this, we come to the end of this session. With due permission of our respected chairpersons, I would like to close this session. And I request our chairpersons, Dr. Frank Kamal sir, Dr. Basumatari sir, and Dr. Krishna Pegu ma'am, to kindly proceed to the felicitation podium for the felicitation ceremony. And I also request our speakers, Dr. Prasanna Kumar sir and Dr. Arathi ma'am, to please proceed to the felicitation podium for the felicitation ceremony. And I also request our chairpersons to please felicitate our respective speakers. And I request Dr. Anamika Fukan ma'am to please felicitate our respective chairpersons. Now we will be starting with the oration of Dr. A.M. Rai sir. Now for the oration, I would like to call upon stage Dr. Kamachi Selvam sir, RAISA member, to chair the oration. Sir, I would request you to please come up on the stage.
For our next section, this will be the oration of Dr. A.M. Ray. Dr. A.M. Ray sir graduated from Calcutta Medical College in the year 1939 with a gold medal, followed by he joined Bengal Medical Services in 1940 at Campbell Medical School as anesthetist. Then he joined Bengal Assam Railway in 1942 at Guwahati. Then he worked at Bria Singh Hospital, Eastern Railways. Later he was transferred to BN Railway in Southeastern Railway and worked at all divisions and headquarters. Was part of the planning and construction of Central Hospital and PMO and CMO. He retired from Railway Brand in 1972. The oration will be continued by Dr. Nilendra Chakravarti sir. Dr. Nilendra Chakravarti sir, ACSD Department of Anesthesia at Bria Singh Railway Hospital, Eastern Railways. He is a distinguished alumni from Calcutta Medical College. Dr. Chakravarti, in pursuit of clinical excellence, led him to RIMS in Ranchi, where he attained his MD in Anesthesia and Critical Care. His entry into the Indian Railway Health Services was through UPSC, which marked the commencement of a career characterized by unwavering commitment to the nation's railway personnel. Interesting story about the Malda tenure of Dr. Chakravarti. Chakravarti's tenure at the Malda Division Railway Hospital is regarded as a period of visionary modernization, serving as the sole specialist anesthesia in critical care for 14 years. He acted as a primary architect of the hospital's clinical evaluation. Under his stewardship, the facility transitioned from a rudimentary equipment to a state-of-the-art modulator operation theatre and a sophisticated 8-bedded ICU care unit. His technical foresight saw the implementation of the Drago Fabius Plus workstation and central care systems, establishing a benchmark for divisional healthcare. Dr. Chakravarti has demonstrated exemplary leadership for a decade. He presided over the scientific committee of the Indian Medical Association at Malda branch, fostering the culture of intellectual inquiry. Since August 2014, in his capacity as Additional Chief Director at the B.R. Singh Railway Hospital, he has been instrumental in upholding the highest standards of perioperative care and critical care medicine. As a senior consultant and NPMS assessor, Dr. Chakravarti has made indelible contributions to medical education. He currently helps the academics and research at B.R. Singh Hospital, directing the DNB anesthesiology program. His role is physically assessing and accrediting DNB, DRDNB and fellowship programs across India, underscores his status as an authority in the field, ensuring that the next generation of anesthesiologists is trained with rigor and precision. Dr. Chakravarti's contributions to the scientific corpus include 9 major publications in index journals such as JIMA and IGA. His clinical focus remains at the vanguard of modern anesthesia, specifically regarding the extensive application of regional blocks and the sophisticated management of difficult airway through advanced technical modalities. In recognition of his transformative leadership, the mastery of art and science of anesthesiology, and his tireless dedication to the mentorship of the medical professionals, we are honored to confer upon Dr. Nilendra Chakravarti for the Dr. A.M. Memory Oration. Thank you.
I now call upon stage Dr. A.M. Rai, Dr. Arvind Rai sir, son of Dr. A.M. Rai sir, who is a retired Chief Medical Director of Southeastern Railway. Sir, I request you to please come on the stage and have a seat. I now request Dr. Nilendra Chakravarti sir to please come upon the stage. And I request Dr. Selvam sir to please felicitate Dr. Nilendra Chakravarti sir. And also Dr. Arvind Rai sir. Thank you, sir. Thank you, sir. We are very fortunate today to have Dr. A.M. Rai sir's son, Dr. Arvind Rai sir, with us. Thank you, sir, for coming. Please be seated, sir.
So friends, my distinguished guests and all the dignitaries who are attending, it's a great honor that the RAISACON has conferred on me to deliver this prestigious Dr. A.M. Rai oration. So due to shortage of time, I'll be quickly going through the slides which I prepared. Actually, it's on evolution of IRHS anesthesiologists and anesthesia in Indian Railway hospitals. Myself, Dr. Nilendu Chakravarti. So I'll be quickly going through the slides. When we joined railways, it was almost a primary care that we used to deliver. From there to the tertiary care, the journey has been long, but it's very good journey. This is our hospital. Indian Railways operates one of the largest specialized healthcare systems in India, comprising around 138 hospitals and 580 plus health units serving 64 lakh beneficiaries. The system is transitioning from a curative model to a digitally enabled modernized structure, including HMIS, specialized services and upgraded ICU capabilities. So these are the key structures of development that we have gone through. There are around 17 central hospitals now. There are 41 plus divisional and sub-divisional hospitals, the primary health units. Northern Railway has the highest number of hospitals. The modernization and digitalization has come in. RailTel is implementing a pan-India HMIS. There has been specialized care. Major hospitals offer tertiary care in cardiology, orthopedics, gynecology and oncology. For instance, B.R. Singh Hospital under Eastern Railway provides advanced cardiology and surgical services. And during COVID-19, we have seen how the railway hospitals significantly expanded, such as creating LMO systems in one instance and administering over 45,000 vaccines. So coming to the historical development, the system which was disparate before 1947 was reorganized with a focused planned expansion beginning in 1954 to ensure uniform standards. And the upcoming trend is now shifting towards public-private partnerships. We are expanding the DNB training programs and enhancing the industrial health services. The challenges which we face include a reported shortage of doctors and paramedical staff, but we are striving to come forward. The Indian Railways has moved on from steam engines to speed, and the railway anesthesiologist has moved from crude to cutting-edge technology. The railway anesthesiologist has moved from the head of the table to the heart of the hospital. Our early beginnings in 1890s to 1940s, the chloroform era was there. There was a chloroformist used to be there who used to be a generalist or a technician. The first shift came in 1930 with the introduction of the Boyle's apparatus, where there were use of early inhalers and eventual introduction of the Boyle's machine in major railway hubs. The anesthesiologist from the ether has now migrated to nanotechnology and robotics. The future involves AI-controlled anesthesia, nanorobotics for transporting respiratory gases like respirocytes, and each personalized drug delivery system has come up for each patient. We are now thinking of using xenon, which is a noble gas that is considered the ideal anesthetic agent due to its rapid, safe profile, though it is very expensive currently. These were the times of ether anesthesia. From there, we have moved to nanotechnology and robotics. The key aspects of the founding and development have been the early origins. Although specific to different railways, medical services began in colonial era itself. B.R. Singh Hospital was established way back in 1934. Systemization took place in 1954. Dr. E. Somashekar, Chief CMO Southern Railway, proposed a plan to expand the medical facilities, leading to a dedicated cell at the Railway Board in August 1955. Then came expansion in the Northern Railway Central Hospital's foundation stone, was laid down in 1955 and it was inaugurated in 1957. Jagjeevan Ram Hospital was opened in June 1960. Then we were organized into Central Group A service. Recruitment started being conducted through UPSC from 1976. And the renaming was done from IRMS to IRHS on 15th January 2020 to distinguish it from the Indian Railways Management Service. When we joined Railways, we mostly used basic boils anesthesia machine and used spinal anesthesia for the obstetric cases. These were the vaporizers which we used, ether vaporizer and some places halogen vaporizer. And we heavily dependent on spinal anesthesia. Post-independence and formalization took place from 1950s to 1970s. IRHS first adopted the standards set by the ISA in 1947. Then came the drug milestones. These two drugs revolutionized anesthesia. In 1949, the introduction of deutubiquarine for muscle relaxation, and 1950s saw the rampant use of succinylcholine for intubation. And at that initial time, after the introduction of these drugs, we found that there was an acute shortage of anesthesiologists in railway hospitals, and cadre creation was attempted way back in 1950s to 70s. Specific recruitment of medical officers with anesthesia diploma, degree or even training was enhanced. Then came the technological transformation from 1980s to 1990s. The modern monitoring system came. The transition from manual pulse checks to pulse oximetry and capnography came. Then came the institutional growth, expansion of major hospitals like Jagjeevan Ram Hospital into tertiary care health units, and the All India Forum was created. So greater professional networking through the Indian Railway Health Service Association was done in between 80s to 90s. These were the pulse oximeters which we were using. This was the capnograph which was introduced in the railway hospitals. Then the academic maturation came from 2000 onwards. The postgraduate training, the launch of DNB courses at Eastern Railway, Southern Railway, Northern Railway Central Hospitals. Then the IRHS doctors involved themselves in research and publication. They now contribute to journals and serve as NBE examiners. Then the standardization came in. The implementation of the IRMM guidelines for surgical safety came in. Then we moved one more step forward, that was a super specialization era. The anesthesiologists mainly super specialized in pain management and cardiac anesthesia. These were the favorite areas of super specialization for the anesthesiologists. The pain medicine was introduced in central hospitals like Jagjeevan Ram Hospital, and which pioneered dedicated chronic pain clinics in 2006 using advanced neurolysis techniques. Perambur developed into a place of cardiac excellence and became a national hub for complex cardiac anesthesia and bypass support. Nowadays, almost all zonal headquarter hospitals in Indian Railways have dedicated pain clinics and dedicated OT for pain procedures. This is a pain clinic in progress, and this is a dedicated OT for pain procedures which we use. Then came the contemporary tools and technique. The universal use of safety technology was the main feature here. Universal use of ultrasounded guided regional blocks and TCI, target controlled infusion started. We started using modern agents like sevoflurane and propofol. The main aim was faster recovery and safer patient safety. So I am proud that I am a part of this prestigious hospital. It's now B.R. Singh Hospital and Center for Medical Education and Research. It's a tertiary excellence hospital. It is one of the few railway hospitals which provide anesthesiologists are available 24/7 for emergency, for medicine, for surgery, for cardiology care. Now anesthesiologists take the lead role in designing all the modern OTs of railway hospitals. This is the modular OT which we designed, the team of anesthesiologists. And these are the surgeries being performed in these modern OTs with latest cutting edge technologies. This is a TKR under progress with many cardiac comorbidities. The patient was referred from Howrah Orthopedics to us and we successfully did the TKR. Then we are not lagging behind even in pain management. In 2015, we performed a celiac plexus block for a critically ill cancer patient, providing complete relief from intractable abdominal pain. Nowadays, pain management for chronic pain, especially for oncology patients, is done routinely. Then came the cardiac and minimally invasive surgery support. The anesthesia team provides specialized perioperative care for complex procedures, including minimal invasive cardiac surgery and rare congenital heart defects, PDA closures, etc. Then the support that we give to the surgical team so that they could do the entirely laparoscopic CBD exploration in 2010 itself. Then very recently in 2025, 1st January, we did a historic intervention that was a multidisciplinary approach. TEVAR, which is called thoracic endovascular aortic repair, was performed in a case of aortic aneurysm. It was a team comprising of cardiology, anesthesiology and radiology department. This is our hospital and this is the TEVAR team. It was in all the leading newspapers that we successfully, without opening, we just provided the TEVAR and complete relief to aortic aneurysm patient. Then came the era of super specialization in critical care and resuscitation. The ICU management was now handed over totally to anesthesiologists, and it's a multidisciplinary ICU across all zonal hospitals. And our obvious role in CPR, the department is the primary authority for CPR and life support training for railway staff. This is the ICU, the anesthesiologists managing the ICU of the railway hospitals, the CPR provided by the anesthesiologists. Then came a major thing, this COVID-19. It created a paradigm shift. IRHS anesthesiologists pivoted the lead in ventilator management in COVID special coaches and hospitals, and the oxygen infrastructure was totally left to the anesthesiologists of the hospital. They spearheaded the installation of PSA oxygen plants and liquid medical oxygen tanks. The anesthesiologists came out as real heroes in saving lives in the COVID era. The general population came to know about the ICU skills of the anesthesiologists. The saviors who always remained within the boundary walls of the OT came to the forefront to save lives in the ICU, and their master stroke in managing ventilators got worldwide acclaim. This was the hospital trained during COVID times. This is the PSA plant and the oxygen we set up. Setting up of new PSA plants for medical oxygen and central pipeline for medical gases for the entire hospital was mostly organized by anesthesiologists of the railway hospitals. Now comes the future vision and summary. The evolution from a technical skill to a comprehensive clinical science. The vision is integrating artificial intelligence in monitoring and expanding daycare surgery capabilities. And the take-home final quote is, safe surgery is no longer an option, it is a railway health standard. We shall strive to have such operation theatres in our railway hospitals in near future. The railway anesthesiologist never gets tired. His new year starts and ends in his own suite ICU. Thank you for the patient hearing.
Thank you, sir, for your great oration. Now I would like to call upon stage Dr. Arushika Rabha ma'am for the felicitation of Dr. Sevlam sir and Dr. Arvind Rai sir. Ma'am, please come upon the stage. Yes, sir. Yes, sir.
I must thank for presenting such an excellent review of the entire transformation of anesthesiology in railways. I have been a witness to it. I have been a member who got that transformation on himself and the departments. I am really proud that he has revealed what BR Singh stands today, and also our hospital, Central Hospital at Garden Reach. We may not be as prominent as BR Singh, but we are on the side of the city, but the developments are also taking place there. What he has also mentioned is pain has come as another specialty under the control of the anesthesiologist, and people are becoming aware of it and taking advantage of it. My grateful thanks to Nilen for excellent revelation of what has happened to our specialty.
Thank you, Arvind sir. I now request Dr. Arushika ma'am to please felicitate our Dr. Selvam sir and Dr. Arvind Rai sir. Please give a big round of applause. Thank you, ma'am. Once again, thank you to Dr. Nilendu Chakraborty sir for the great oration. I request all the RISA members to please be present in the auditorium for the RISA General Body meeting. Thank you.
थोड़ा हमारा प्रॉब्लम जरा এটা অফ করি তিন নম্বর হ্যাঁ তিন নম্বর কঠিন আইটা কি এগুলো মোবাইল জ্যাক একটা হ্যাঁ জি একটা দুধ লাগানো আছে হ্যাঁ একটা সিস্টেমটা অফ কর টোটালি অফ
हेलो बोलिए।
Both in the abhi the conference head is with the RML hospital, so I've talked to them. They're putting one of our members there, so